simulated individually, running in a given physical configuration that at the same time is a plastic configuration. So the shape of the respiratory tract is flexible, and the trajectories of the particles can be followed individually. What they can use this for, the example in the figure, is how this can be personalized to some extent, trying to understand how different configurations of the respiratory tract will influence in the way the drugs that are fabricated in the form of aerosols are flying over the respiratory tract, understanding where they are hitting and what can be the best way, what can be the best design in terms of the size of the particles. This is another simulation, just to give one other example. Same thing, trying to simulate at the level of an organ the movement. In this case, is movement plus some of the electrostatic properties. One of the things that they can use this type of systems for is to map back real experimental data, trying to understand how the data fit with the different movements and the different conditions on this particular simulation. So it's a way of coupling data with simulations at the level of organs. Obviously, there is much more to do. This is only two examples, two organs. There are many other systems that will have to be simulated at this level. So it's interesting. It's a very consuming task because, like in the case of the particles, to be able to get data in a realistic way from that, you need to simulate many times, many millions of particles, and this is done with fluid dynamics equations that are pretty expensive to calculate. And there are many questions then, when you do these simulations, there are many questions that we can ask, questions that are related with the overall performance of the simulations, how to find the key points, how to find specific events on the simulations, and also how to organize the computers to perform the simulations in the most efficient way along the trajectories. So this is nice, and it's a full activity in this area. Still, there are many things that has to be solved before we can really profit in biomedicine, in biology, from this type of simulations. First of all, as you may realize, these simulations are not related with the cellular level. They are done at a very macroscopic level, but it's impossible, how things are done now, to understand the relation between what is happening in the simulation and anything that is happening at the molecular or the cellular level. They are right now completely disconnected. Second, it's very difficult to personalize. It's very nice to have this general model, but it's very difficult to say this is the model for this particular person in this particular condition. So this going from the general to the particular is also going to be a very, it's a very much needed effort, and it's something that is not there right now. And it's difficult to find applications. The simulation is nice, you see things happening, but how are you going to use this information? Is the simulation telling you more than the experimental data that you use to build the simulation? And we already discussed this topic yesterday. The perfect simulation will be the one that is providing the data that you already have experimentally. So it's still I would say, a very much on the debate topic, how we can, what is the right level in which this simulation will tell us things that we don't know. Obviously, the other way to go about that, the other way we are exploring, like many other groups, is going, instead of bottom-up to the big systems, going top-down, start from the molecular level. What we would like to do is to simulate, for example, in this case, tumor with all the complicated microenvironment, the different cell lines in the tumor, the immune infiltration, all the conditions of oxygen, possible drugs, and everything. As you know, to do that, we are using a combination of molecular models, models of pathways, or metabolic models, most likely represented as Boolean models to make things feasible. And at the same time, we are using cellular automatas, agents, to represent cells. So in the pictures, each one of the dots, each one of the small balls, will be a cell that is informed with a particular model of the cellular state represented by a Boolean model. The simulation is not running, doesn't matter. So in our case, we are using this combination in collaboration with groups in Curie and Indiana University and Norway, models of the molecular level, models of the cellular level, trying to reproduce the conditions of tumors and making simulations that will reproduce things like, trying to understand things like what is the response to drugs. So all this is ongoing activity. Obviously, there are many difficulties at this point. Difficulties that have to do with lack of data. When we want to reproduce the molecular level, we know that we don't have all the information about pathways or metabolic conditions. We don't have all the parameters to do these simulations. So we have to jump over the things that we don't know, and we need more data to fulfill many of the conditions and the parameters on the equations. At the cellular level, we have done progress trying to understand how is the response of individual cells to treatments, for example, to drugs, but still, in most of the cases, the simulations are still not very, at least it's very difficult to move simulations to be able to reproduce conditions like drug treatment or like synergies between drugs, or even to reproduce the different behavior of different cell types to a given drug. If we want to move from the cellular level to the multicellular level, all these difficulties will be even more complicated once that we want to understand how the cells are interacting and how they are interacting with the environment, whatever this is, the extracellular matrix or the conditions on a tumor. In most of the cases, I highlighted in the slide the lack of data. We are facing a problem that, as you know very well, is fascinating but extremely complex, a problem that is far more complex than the problems that physicists have been facing in their simulations. And for such a complex problem, we need data, and I guess this is what we are here to be able to generate enough data to try to solve some of these problems at the molecular, cellular, or multicellular level. Even if we can solve the problems at all these different levels, we will still have a problem of integrating the information from the molecular to the cellular to the multicellular level. This is called the multi-scale problem. There are many different groups working on that. There are very good work done by centers of excellence, the BioExcel Center of Excellence. There are all the development that were done by the different national projects. I highlighted here the German Virtual Liver project, or all the ongoing activities of the virtual physiological human. So it's not that there is not activity in these areas, it's only that the problems and the challenges are very big, and we have to really do a lot of more work on the simulation side, on the data gathering side, to make progress. And I would say the only thing that I can say is that the only solution to these problems is to go and do it. We need to get more data, to do more simulations, to generate more results, and to go back to more simulations. And there is no magic solution to any of these problems except working on them. So this is from a failed competing proposal that was called Digital Twin. The proposal failed, as a pity, for a number of reasons. But still, the paradigm of that, I think, is an interesting thought. So digital twins, as you may know, is the term that is used in the industry for the systems that are producing simulations that are running in parallel with the real system and trying to foresee what is going to happen with the real system in a way that there can be measurements on things done to prevent a number of events. I give you the typical case, will be a car factory. It's a big complex thing producing cars. There's a digital twin system running in parallel that will run in as much as possible a similar system to the real car production system in a way that they can predict what is going to happen. Are we going to run out of some of the components? What happens if we stop it here? What happens if we change from producing one thing to producing another thing tomorrow at 9 in the morning? So these are the typical use of the digital twin system. The idea here was a digital twin for medicine. Can we do the same thing in medicine? Can we have, in the example was Anna, going to the clinic, getting some measurements done. In this context will be single-cell measurements done, but you can imagine that in a real medical scenario there will be many other things, many other type of data that will be required. Can all this be then shift to the digital world, to the digital Anna, where there will be a model of Anna that will be fed with the data, produce some experiments, some possible treatments for this condition of Anna, and the information will be sent back to Anna. Obviously, it will be easier to do experiments in the digital, with the digital Anna, with the digital twin of Anna, and at the same time, many of the conditions could have been pre-calculated for many of the events. And then the information will be back to the real world, and the clinicians and Anna will take a decision about what to do. Obviously, this is a scenario that is not possible right now. I just showed you what is the level of simulation that we can do of some organs, so there is no digital twin that we can implement right now. The question for me is this something that will be possible in the future? And when is the future? The future is in 50 years, in 20 years. How much can we do to speed up the process? Because the truth of all that is that we need systems to help clinicians to take decisions. And these systems are going to be, sooner or later, around this paradigm, sending information to a digital system that will give us possibilities, possible scenarios of treatment, possible solutions to a given problem. So these are, for me, interesting questions in this setup, in thinking in 10 years from now, how much of this can be implemented in the real world? For what systems, in what specific cases, with what limitations? Obviously, high-performance computers can be used for simulations, show you some of the possibilities. They can also be used for other things, and in this context, it's particularly interesting, from my point of view, to explore the possibilities of understanding networks. Many of the problems in biology can be phrased in this language of biological networks. In our case, we are interested in problems related with genomics, splicing, and chimeric constructions, chimeric proteins and chimeric RNAs. The problems of relation between diseases. We were talking yesterday about disease focus. More and more, we think in diseases not as a single type of disease, but diseases given by conditions or subdivisions of diseases in a smaller subgroup of cases. But at the same time, in real life, diseases are not happening in isolation. Diseases are happening, unfortunately, to people in combinations, comorbidities, the presence of different diseases in the same person. So understanding the relation between diseases becomes not only a very important medical topic, but at the same time, a very interesting tool to understand the biology behind the diseases by understanding the combinations of diseases. And obviously, we are also interested in other types of networks, in these cases, networks that are related with epigenetic information, representing chromatin capture experiments in the form of networks as an alternative way of analyzing the information. And there are many other ways in which we can represent, there are many other areas of biology that can be represented as networks. Networks can be very interesting, but can get really very complicated. I give you a very simple example of how easily and how quickly complexity grows in any biological problem. We were wondering about this very simple problem, how to find the relations between two ontologies. This is the gene ontology, describes biochemical information, essentially. And the other one is HPO. This is an ontology that describes symptoms. The two ontologies are related by genes. There are some genes that are annotated in the two ontologies. So in principle, we can imagine ways of connecting the information from one to the other. This is a rather simple thing. We can say something like, I have this type of symptoms. I don't know to what biochemistry they can correspond, so I can go to another term, I can go to a gene, I can go to a gene ontology term, and find a relation. So I can do this type of exploration, connecting information from two different ontologies. So in principle, this is a very simple operation. I have two ontologies, they are not that big, and I want to be able to connect them. Once that you try to do this systematically, the thing gets complicated. The number of possible connections for these two ontologies is around 600 million connections if we are only exploring 4 jumps from 2 in one ontology connected with a gene. If we want to do a larger exploration of 6 or 7 possible pathways, the number will grow exponentially, so we can be really very big explorations. To do that, to be able to explore this network, to be able to travel between these two simple ontologies, we end up in a very deep problem of exploring very large networks. And then you end up, again, in the need of methods to do that. In this case, it's a collaboration with people working in my institute in massive parallelizations in a way that we can really explore all the possibilities in a computer for these 600 million combinations. So network biology is a good way of exploring biology, but as soon as you enter in any of these problems of networks, you end up facing very complex algorithmic problems, and many of them are highly demanding of computational power. So all this is about things that we can do with the data, but then to be able to do things with the data, we need the data. So in the next part, I will tell you a little bit about how we deal with biomedical data in the context of bioinformatics and some of the European infrastructures dealing with biological data. And some of the ideas, then I will tell you something about some of the ideas of what we think can be avenues for new developments in the future. We are not the only ones producing data. As you know, physics is producing data in quantities that are similar to what we produce in biology or even more. I give you 2 examples. This is Gaia. This is a project from the European Space Agency. This is the map of the galaxy, trying to map all the stars and all the planets or things that we can find in the galaxy, or the distance with the other galaxy. The numbers they are talking about is, depending on the level of distance and resolution, well, a few hundred or thousands of millions of events, of stars, or objects, if you want. This is a very large project with a very, all the countries involved, very big networks, all the observatories, all the different type of instruments sending information, and then it's a database collection problem. The database is at the Barcelona Supercomputing Center. We have the same problems that we have with the data. The curation of the data, not losing the data, getting data from large providers and small providers, the quality of the data, being able to compute on the data to do all this, to find the elements, to find the distance, to find the properties of the different elements. So it's, with enough organization, this can be done, and this project has been running for a number of years very successfully. So in a sense, it's good to think that we are not alone dealing with this type of large-scale and data problems, and this has already been solved in other areas. This is from the large-scale project on particle physics. There's people around the CERN, the Super Collider. Same thing. There's a paper a few weeks ago, beginning of the year. Open is not enough. It's not enough with having all these data from the Super Collider. They need to be able to compute on the data and to compute on the different phases of the data and to be able to recover all the data that they have done in the different experiments. So again, large-scale consortiums, very well funded, very well organized, handling very large scale, very large data set of, in this case, probably of 10 times, with 10 times larger of what we have right now in biology. So the alternative and you have here all that in biology is around fair principles, making the data findable, accessible, interoperable, and reusable. As you know, this is absolutely popular with agencies. There is no local agency, there is no international agency that is not talking about making the data public. And I cannot say there is nothing wrong with that. We obviously want to have the data open and accessible and being able to use it. I mentioned two different efforts, European efforts, which you have already heard about. One is the European Open Science Cloud. It's still a little bit unclear what is going to happen and how this is going to develop, but certainly there's a political effort in putting together the different organizations in Europe to be able to provide data in an accessible way. The other one that was already mentioned yesterday, and I think is particularly interesting for us, is the initiative for medicaments in Europe. This is the largest public-private partnership in the world. Pharmaceutical companies, now there will be other companies too, and the European Commission putting huge amount of money into different type of consortiums generating data or analyzing data. Now, in the transition between the second phase of IMI and the possible new project that will have a different name, one of the key considerations is, along these years, what has IMI produced in terms of data, where is this data, how this data can be analyzed, how the data can be put in value for the companies and for the public. And I think we are in a very good position to influence how the next phase of IMI is going to develop, because this is really moving huge amount of money, and is also directly connected with the interests of industry. I will be careful about all that. And yes, it's important to have all this data accessible. This is not the only mission we have. It's not only making the data accessible, it's being able to generate the data and being able to analyze the data. So if I want to put this in a moderate way, I would be very careful about what is the effort that we have to dedicate as a consortium to do science and to keep the data. If we only put effort in keeping the data and annotating data, we will not progressing in science. If we only do experiments and analysis and we don't put any effort in keeping the data in a proper way, we will not contribute to the overall progress. And the balance, I think, is very important. Obviously, Europe is getting organized to do these things. Elixir was already mentioned. This is the European Bioinformatics Infrastructure. I'm sure you have heard about that. This is organized in nodes in different countries. Every country is organized also as a network inside the country. A number of these developments are very important for what we are doing here. The European Genome Phenome Archive, the database that is storing the information of human genomes, the Beacon project, ways of analyzing or asking for what information do you have in a repository without breaking the laws of confidentiality, being able to understand where is information about a given mutation or a given phenotype. All the efforts of Elixir in providing a single identifier for all the resources in Europe in a way that you can explore information in different repositories without having to have a new certification, a new identification. All this effort of Elixir. Elixir is now a partner of the Global Alliance for Genomic Health, and all these three projects, the genome, the EGA database, the Beacon project, and the Elixir identification system are at the same time projects of the Global Alliance. So all this is working not only at the European level, but at the international level. I just wanted to mention one of the efforts in the context of Elixir, because I think this also can be very relevant in the context of the talks of these 2 days. One of the things that we are more interested in the context of Elixir are automatic systems for benchmarking bioinformatics methods. So we are interested not only in providing methods for analyzing this. In this case, in this example, for example, text mining method will be the next example. Not only being able to provide the methods, but also to provide, together with the methods, the systems to evaluate them in scientific and technical terms, and being able to do this live in a way that, as a biologist, you will go to a web page and say, these are the methods for analyzing multiple sequence alignments, and according to the last benchmark, this is the one that is working better for these conditions. And to be able to keep, so these are the technical developments, not going to enter into the details, obviously, but these are the technical evaluations, and these are scientific evaluations. In this case, the method is for methods doing finding orthologs, but this is just one example. So this will tell you if the systems are up and running, how much time do they take, and this will tell you what is the best performing one according to a given data set. And we have put an effort to do this for many communities, trying to make a system that is a stable and general benchmarking system. This has been in many different domains. I'm not going to say much about that. This is text mining. There is a big effort at the scientific level and at the technical level to provide systems able to understand or to interpret or to extract information from text. This is particularly relevant in biology because of the difficulties in extracting information from medical records and from medical information. There are developments related with information extraction at many different levels, and their infrastructures. OpenMinted is an European infrastructure, in a sense equivalent to what is Elixir in the domain of bioinformatics, dedicated to provide methods and systems for extracting information in biology, in biological terms, or biomedical terms. It's important here the problem of the languages. Now, if we do this extraction of information in medicine, we will do this in the medical records, and the medical records are written in the specific language in the different countries, so the extraction problem becomes a problem of extracting information in a multilingual setting. Two ideas here. So there are many developments on the computational side, thinking on how we are going to be able to access the information, the medical information that is distributed in the different hospitals and the different repositories, and how we are going to connect this with the different methodologies. The two ideas we are discussing these days are these two ones, the patient dossier and the continuous computing. Just to say this in a few words, the patient dossier is the idea that instead of asking the systems to do a lot of work at the level of the data, we want to put more the burden of the problem in the question, in a way that when a physician or a biologist is asking a given biological question, he or she will not have to worry about where is the data and what are the methods. The question itself will be written and formulated in a way that will be able to find where is the information, what is the right information to use to answer this question, how to access the information, what are the conditions for accessing this information, and what are the method repositories and the specific methods needed to answer the question. So in a sense, we want to put the effort in the formulation of the question at the computational level in a way that the user will not have to worry about all these details. And something similar is for the continuum computing. The idea is that the user will not have to think about, for this data, I need to use this computer because it is accessible or easy or the adequate one. The system itself will be able to take the given question and find what is the right environment for a given question, trying to do the computation in a faster, more efficient way possibly close to the data itself. So these are concepts. The question is how to go from these conceptual frameworks to actual implementations, and this is what we and many others are putting effort in doing. One thing is obviously then is to have this data in the different repositories, in the different databases, being able to find the information, being able to handle the information. The second question is what is called the data integration problem. The ways in which this can be described, or the way I want to explain this here today, is using multi-layers. That is one of the possible approaches to this problem, combining information on different levels. The examples, the easy examples are these type of things. These are 4 scientists going to 3 conferences, so you can now map how these 4 scientists are interacting. They are interacting because they talk to each other or because they went to a talk that was given by the others in the 3 different workshops, and then there will be different relations, and then you can start integrating the information, trying to find what is the the relation between them, and at what level they are transferring ideas from one to the others. The thing can get more complicated. This is another approach based on networks. This is for someone traveling in a city, how to connect the information from 3 different transport systems, the tram, the metro, and the bus. These are the metro, bus, and lines, and then you can start mapping how different people use the different transport systems and how the systems themselves are linked. So we maintain information in different layers. The layers are connected because the metro station will be close to a tram station, and then you can start tracing how different people move to understand what are the main use of these transportation lines. In the case of biology, we can use these multi-layers to find trajectories, how genes are connected, for example, or communities, how different genes or proteins are performing common functions. There are many things that we can put in these multi-layers. These are examples, physical interactions, drugs, mutations and variations, pathways, or reactions with metabolites. As soon as we start putting this information, the number of trajectories connecting all this information in this estimation for this particular data set, the estimation is around 100 million trajectories. So handling this information, 100 million trajectories becomes a problem, an interesting computational problem. Can this be useful? Show you examples without entering into the details. We are using this to understand the relation between severe and less severe cases of a given rare disease. If you do this by simple integration information, you don't understand the relation between the genomics of these 2 types of cases for this disease. If you use typical functional enrichment analysis, you start seeing things, but you cannot really understand very well the differences between the different types of the diseases. When you use multi-layer analysis, then you can really go deeper and understand the relations between these two types of diseases. And again, when we use this information, we obviously face problems. This is an example mixing information from electronic health records, transcriptomics, symptoms, and microbiome. And then the thing becomes really a new and complex problem because we don't have the same individuals in all the layers. We don't have a person for which we have all this information. We have information from a group of patients at the level of medical records, another group at the level of transcriptomics, another group at the level of symptoms, and another group at the level of the microbiome. And now these relations are not one-to-one. It's a complex setup, and there are solutions to be explored to solve these problems. So data integration is a complex problem. Having the data accessible is not enough. How to interpret the data becomes really a complex problem by itself. I showed you one type of development. We are interested in this multi-layer. There are many other possible ways of analyzing information, but this is, I would say, a particularly promising one. And all these computational methods are really very demanding of computing time. To finish, I have a couple of slides on artificial intelligence and machine learning. This has been already discussed yesterday, so there is no need to go in any detail, and I'm running late. We have a lot of hopes, and these are some just 2 recent papers, Atul Butel and Eric Topol, on the promises of machine learning in particular, in providing systems that will help doctors in the process of taking decisions. The truth is that this system are already in use in many areas of engineering, but we have more problems in biology, or there are less of these systems accessible in biology. Still, things are working. This is an example from Andrew and Jay, assigning cases of arrhythmias. And machine learning systems are better than the doctors in classifying cases of arrhythmia, what is not surprising because it's just a very accessible computational problem that does not solve the problem of the treatment of arrhythmia, only solve the initial problem of the classifications. There are many applications. This is a particularly interesting one. I'm not going to enter into that. You probably have seen the papers solving or making a big progress in predicting protein structures. A very open and complex problem. Now, Google DeepMind has made a lot of progress on that. So there is actual progress that can be done with machine learning techniques in very hardcore molecular biology problems. this is, in a sense, even if machine learning is not new, what is new is the new type of deep learning techniques. It's probably very much of a new development. And everything has to be taken with care because the applications are very powerful, but at the same time, the publicity around these things is not always very positive, and we are in the point of producing a counter-reaction. These are what are called adversarial networks, systems that are able to confuse the classification systems, and these are all the possible ways in which a hospital system can be attacked by these adversarial networks that will confuse the classification system of the hospital, will, in a sense, hack the hospital systems. And this is the reaction of the Spanish newspaper wondering about that. So artificial intelligence has a lot of promises, but for different reasons, the public perception may not be as positive as we think it is, and this is certainly dangerous. Sorry, I'm running late. I'm finished with that. So I showed you a number of possibilities for the use of high-performance computing. These are new machines. These are new machines for machine learning. This is getting very big. The largest computer in the world is a computer designed, or with a design that is very appropriate for doing machine learning. Just to give you an example, Europe is running late, but they still putting money, hundreds of millions of euros, in buying new computers, and this will be probably very adequate for making machine learning, for making machine learning applications. So artificial intelligence is not a single thing. Deep neural networks are not new, but they are not magical, but they are very powerful. We need still to understand better how they are working, and there are many other alternatives that can be implemented in biology. So I finished with that. As I say, I just went through all the possibilities, summarizing many of the things that were said yesterday in terms of the data, the importance of keeping the data, annotating the data properly, that we are making real efforts and progress in being able to put the data together and doing data analysis. And this data analysis in form of networks or the computational systems has to be put along and together with the simulations if we want to make progress in providing biomedicine with systems that can help in the decision progress, integrating molecular information with other type of information. Thank you very much. And we are late.
Yes, but it would be really good if we can have a discussion around all the topic of interest for LifeTime. So, questions?
Hi, Alfonso. So you covered a lot of ground. Difficult for me to follow everything. But what I was really interested in, and I'm not sure if you talked about it, but let's say, even if you did, could you clarify or tell us about your thoughts about how people active in LifeTime would connect to what you do, or how you would connect to them, or if you think there's an interest in this really?
Well, I hope I say something about that. So from my point of view, we are in a very critical moment in which a number of fields that were completely disconnected until now, high-performance computing, that is a big investment in Europe, it's a big investment worldwide, it's a big investment in Europe, the biomedical infrastructures, Elixir and the like, trying to organize and maintain the data, the initiative like IMI connecting with the pharmaceutical industry that is in a critical point, trying to decide what they are going to do in the future. These are like three main big investments at the technical, scientific, and economical level that are right now disconnected but getting increasingly interested in understanding each other. What they are missing, from my point of view, is a vision of how this is going to be progressing in the future in a way that real progress can be produced by understanding the underlying processes behind diseases. So there is the interest of high-performance computing, the interest of the biomedical infrastructures, the interest of the industry around IMI in understanding the causes of diseases. And to be able to do that, they need the initial molecular data. They have the tools on the high-performance systems. They have the tools and the systems to keep the data. They have the tools and the systems to do drugs and drugs developments. They need to have the models of how the molecular processes are working. And this is the connection. This is the right time to put all these efforts together under the light of how we get the molecular data that they need to make progress and being able to build on these infrastructures.
Thank you. So Fabian, please.
Thanks for a nice presentation. It's really interesting how you describe sort of this HPC angle, and particularly in physics, also in some physical simulations, you show very nicely that there's for sure a need for these high-performance computation-based simulations. I guess 10 years ago, so when we started with systems biology, right, we also had this overly promise that we can build up bottom-up models. But I think for some reason we weren't able to integrate the data so well. So you're saying we should take that up again, or should we more focus on the machine learning techniques which are not doing so much of this molecular thing? So you're basically your first part of the talk, which was more network, bottom-up, and then this data science-based things. Do you see these things, these connections now happening in applications that you're studying?
I think that, like many things, and what you describe you describe this in a very good way. Like many things in science, they go in ups and downs, times of up and times of down, no? And we have seen this in, machine learning is a good example, the natural language processing is another good example. I think that we are now in a critical point in which we can, again, try to build bottom-up systems because we understand better the data, and we have data in a way, and this is what you are representing here, in an unprecedented way. This was not possible to do it 10 years ago because we didn't have the data and the data integration. Data and data integration and machine learning, for me, are fusing in a single thing because we need the data integration, the machine learning to understand the data. If we only do that and we don't put this in a simulation framework in which we can foresee what is going to happen, do predictions, and go back, it will be very difficult to interpret the data. So I don't see, at least in my mind, there is not a conceptual difference between all these approaches. They have to be part of the same thing. Yeah. And we are in a position now which we can use the computer system that we were not able to use before. We have the data we didn't have before, and we have new techniques that we didn't have before. So I think it's a time for a new app on this type of approaches.
So this is a fantastic pitch for Work Package 3-4 intro, I would say. Thank you so much.
So it would be great if some of the medics in this audience could perhaps raise their voice and comment, because I feel that it's really important for all the different type of people to really see where the challenges are, and with the spirit that we are trying to develop with LifeTime, get a good communication throughout all the aspects that we do encompass. And so I would like one of you in the audience to sort of say, how do you see, from the perspective of a doctor, the interest of linking up with these approaches and the way dealing with your patient can be improved? Okay, good.
Yes, my name is Thomas Gasser. I'm a clinical neurologist, the Hertie Institute for Clinical Brain Research in Tübingen in Germany. And this is actually a topic that is discussed on many levels. For example, there is a German initiative, a medical informatics initiative that tries to make clinical data that are acquired in routine clinical practice available to research and to build models and so on and so on. And it turns out a little bit like Fabian Theiss says, we start with big hopes, and it turns out that when we crash on the hard floor of reality, that there are many obstacles. Data protection is one, but only one. Very heterogeneous procedures in clinical settings is another one. Data compatibility between one hospital and the other, between even one department in a hospital and the next department, is usually not there. So I think it's extremely important. And looking at this program here of the meeting, I already noted that there was very little representation of, that there was a lot of focus on diseases, and that the target of the program is to give better cures and better diagnosis to diseases, but there was very little representation of the medical world, the actual clinical world. Here, having heard yesterday's talk, I think it was very justified because you focused very much on the methods, and the clinicians could have only told you we are not there to provide the data, but I think that it's very important to keep that in mind for the future trajectory of the program.
So it's good that you're mentioning this, because there will be, for sure, in the next part of the session, a lot of discussion where the medical aspect should really engage strongly. But I really wanted to sort of already make sure that people raise their voice. So any other comments in that direction? I think this is the forum for discussion. So please go up.
I think that one could already go very far with setting up a couple of cohorts or linking up on clinical cohorts. I'm myself a researcher in the Alzheimer field, and so in UK they have several large cohorts where they follow people over time to see how they evolve. And so there are usually already measurements in place to keep the data and to give open access. And also I'm thinking about biobank, where you have then this type of information. And so one of the things I would like to see to happen in this consortium is that we have that type of cohort for different diseases, and link that to the data, and link that to genetic data, and then link that to a method to get access to fibroblasts or blood cells from these patients, which allows us then to make iPSC cells which cover the genetic risk, and which can then use for polygenic risk scores calculations, which we can then link back to the clinical information which we get from these cohorts. And these cells can then be used for basic research, where you can go in any direction, chimera, etc. And so I think this is feasible if you do it, if you don't want to encompass everything, but if you say, look, we select 10 cohorts or 10 consortiums of cohorts, and we define upfront the access and the confidentiality and the ethics around it. And I think that would be an enormous weapon in our enterprise.
Thank you very much for this comment, and I'm sure that we will be discussing this kind of aspect a lot further. So I think we should probably move on. Thank you very much, Alfonso, and I think the discussion will go on. Oops. So I think we have now a pitch on aspect related to a work package on communication. And so this is, of course, important in relation with the public, the patient, and all the stakeholders. So, Dr.
Good morning. I'm here, as you can see, to talk about communications, public relations, and lobbying. And this is, of course, something that isn't very often on stage for a project like an initiative like LifeTime, but it is a very important support function. Because communication, we do it all the time. You talk to your families, you talk to your work colleagues, we talk on the phone, we write text messages, emails, we spend time in video conferences. So communication is a very, very important element to make an initiative that is as synergistic, transdisciplinary, and big as LifeTime possible. So now I would like to give you just a short outline of the things we have done so far and where we want to go in the next year. So let me start with social media. You probably have noticed that we have now a very, very active Twitter channel. So there you see a little, an example of the tweets that have been prepared by our communications officer and that have gone out all through the conference. And we will also introduce a Facebook page, a LinkedIn page. We will try to be active on all social media. But of course, many of you, and I hope all of you, know our website. Please let me remind you that there is actually the point support. You can sign up there and publicly declare your support for LifeTime. And this is very important for us because it allows us to show it to the politicians how important this initiative really is. And at the moment, the website mainly addresses the scientific community, but in the future we also plan to have a section that is more for the general public. So LifeTime has also been present in print and online media. I only show you a selection. I don't exploit all of the things we've done here. So you see there was an article about Nikolaus in the Süddeutsche Zeitung, something about Geneviève, something about Giuseppe La Repubblica, and of course it was always in the context of LifeTime. We have staged a number of events for scientists, and again, this is only a selection. So there has been a meeting or at the EpiGen final meeting in Venice, that was last year in Italy. There was an information event at Institut Curie in Paris in November. In February, there was an event at the Belgian Academy of Science in Brussels, another event in France at the IGH. And I'm sure there have been more events that I don't mention here, so please don't be upset if I don't mention you. And of course, there have been lots and lots of general information and lobbying events. And again, this is only a selection. So we've had meetings of the scientific counselors of embassies. There has been an information event at Brussels that was targeted towards politicians and other stakeholders. There's been the Falling Walls event with a special section on LifeTime here in Berlin. And very importantly, we have had a meeting at the Science and Technology Options Assessment Panel unit at the European Parliament in Brussels, which was a very, very great success. We've had very high-level attendance from people from the Parliament and the Commission. And we are very hopeful that we can follow up for a second time. There has been another lobbying event staged by the French Avison network in Brussels. And we've also had connections with journalists to inform them about LifeTime, so we hope that they will all write about it. And of course, what I don't put down here, but what has been happening is, of course, that many of the LifeTimers, and especially Nikolaus and Geneviève, have spent countless hours talking to politicians and important stakeholders to rally the best support for LifeTime that there is, and they keep on doing it. And here I just want to show you a little example, but I don't know how this is going to work. Sorry.
Wissenschaftliche Exzellenz.
Okay.
Wissenschaftliche Exzellenz und Internationalität gehen Hand in Hand. Und deshalb wird auch die internationale Nachwuchsförderung sehr groß geschrieben. Und das finde ich auch sehr wichtig, dass wir nicht nur über die Forschungsbereichgrenzen hinweg zusammenarbeiten, sondern eben auch über die Grenzen von Institutionen und Ländern. Und dass Sie von Berlin aus hier dieses LifeTime-Konsortium koordinieren, unter Beteiligung der Heldenholz-Gemeinschaft und gemeinsam mit Partnern in Frankreich. Das ist auch eine sehr, sehr gute Nachricht und ich begrüße die Gäste aus Frankreich und werde morgen nicht extra nur wegen Ihnen nach Paris fahren, aber von meiner heutigen Erfahrung berichten. Denn gerade im Bereich der Wissenschaftskooperation haben wir uns noch viel vorgenommen. Im Aachener Vertrag sagen wir ganz explizit, dass wir auch im Bereich der künstlichen Intelligenz zusammenarbeiten wollen, ein gemeinsames Netzwerk bilden wollen und da passt das hier sehr gut. Es wird in diesem LifeTime-Konsortium von mehr als 120 Wissenschaftlerinnen und Wissenschaftlern aus 53 Forschungseinrichtungen in 18 Ländern gestützt. Da kann man einmal auch sehen, was globale Zusammenarbeit bedeutet und dass multilaterale Zusammenarbeit in manchen Bereichen auch noch sehr gut funktioniert. Der Bundesregierung ist es
So this was an example actually of the opening of the BIMSby building here in Berlin. And we were very happy that we've managed to get support from a very, very high level. And now I give you a little outlook on what we are going to do in the next year. So we want to, of course, develop a comprehensive communication strategy and plan, which should form the basis for a future initiative for the next year, for the years to come. We want to produce a lifetime video or a series of videos, but we will also do a publishing and dissemination strategy based on open science, and this we will do together with the Research Alliance EU Live, so we're very lucky that we don't have to start from scratch. A part of Work Package 8 is also knowledge mapping of relevant expertise, knowledge and repositories, technologies and infrastructures. This will feed into the work packages, the scientific work packages, and also in the Lifetime Academy. And of course, we will keep on doing lots of PR and lobbying events to maximize the visibility of Lifetime and to make sure that it really can go on. Here, I would like to mention a particular activity of Work Package 8. We want to do a public consultation, and I have to say, it says here, because it is from the proposal, it says exploring the concerns, fears, and ideas of patients and citizens. But actually, we've discussed this just in the last few days. We will aim this public consultation at the general public and not at patients, because they're two different target groups, and you have to be careful of how you do this. And again, we don't have to do this all by ourselves. We can do this together with the Horizon 2020 Project Orion, which is coordinated by Lifetime partner CIG in Barcelona. And with this, I can just show you the people who do the work. This is the team of Work Package 8, but I would like to say that many more people are involved in communicating Lifetime, of course, and I don't have the space to list them all. But here you see the three work package leaders, Wolf Reich, Leila Perrier, and Stefan Preibisch, and my colleagues. And thank you. Any questions? I doubt it.
So we are moving on with Maria Elena Torres Padilla for the next aspect of this cross-work package section.
Thank you. I have just a few slides, maybe.
Maybe. We all hope.
I see them there, but not there. There you go. So I am Maria Elena, and I'm co-leading the Work Package 9 together with my colleague Annelien. And so this is related to what we call ELSI, and that stands for Ethical, Legal, and Societal Issues. So very quickly, I will just tell you what we are in charge of doing during Lifetime, because I'm sure that, as you can imagine, there are a number of ethical and societal issues in addition to the legal issues of data sharing that have been discussed that we expect may actually arise from the research in Lifetime. So really, in a nutshell, what we are in charge is doing a little bit of benchmarking, and that just basically means identifying the potential ethical, legal, and societal issues that are associated with and emerging from the research programs that we have been discussing over the last day. And that will be used to propose a number of concrete measurements for implementation for Lifetime, so that we actually deal with the ethical and societal issues. And the idea is as well to develop a mechanism where we continuously monitor and resolve these issues during the Lifetime. So this is not just 1 year endeavor, but really to try to put a strategy with a 10-year horizon. And also the last point is actually to integrate our work right here with the public engagement strategy that Dirk already spoke about. And I just have a little cartoon to tell you that really the goal is to generate an overall framework of our working Lifetime, so that is obviously centered on research, but that takes really seriously the expectations from the public in general, but including these ethical issues. A lot of it also probably will come from the use of artificial intelligence, and there's a number of interdisciplinary aspects of the research that need to be taken into account, and also accountability and engagement with the public, and so on and so forth. So the first action that I would like you to convey, and also to ask for some of you who actually would like to participate, is we are having workshop to try to actually have a first discussion with experts for these issues that we actually have to identify. So the workshop will take place on the 10th of July at the Stem Cell Center in the Helmholtz Center Munich, where I work. And we actually divided the panel in two. So on the first one, we are going to be discussing the ethical implications and societal impact. And we will have a second session where we will want to discuss more legal implications and responsible research. And I'm actually very happy that we have quite a number of experts from a number of areas that already accepted our invitation to come. So with that, I will just finish and tell you that this is the team. So as I said, Annelien and myself are co-leading the package, the work package, and we have a number of colleagues that are already committed to help us throughout. And I just put a little note here, so this is not closed, so whoever in the room, I have been approached already yesterday, wants to join forces to help us, please just come and talk to me. And with that, I will just let the room to my colleague, Karin, who will give you a little bit of introduction, a very short example of what we can actually do to deal with the ethical issues in LifeTime. Thank you.
Okay, so now that we've heard what we are actually going to do in our work package, I thought it would also be very nice to say something about how we do ethics research, because I picture that it is very different than research how you do it in the lab or in the clinic. I'm here on behalf of Professor Annelien Bredenoord, who is a professor for biomedical ethics of biomedical innovation in Utrecht, and I work very closely together with her on topics of the ethics of innovation. Well, I think yesterday and today we will hear a lot about these new and exciting technologies that have very promising implications for society to fight diseases and understand better how diseases happen, how we can make or keep people healthy. And these new technologies, that is not specific for the technologies that are central in LifeTime, but actually most technologies within medicine have societal implications. As you can see here, protests show that society has an opinion about it and has a stake at these technologies that are being developed. So that is also no wonder. As I said, the goal of also the LifeTime Consortium is to tackle centrally societal questions about health and disease. So it's no wonder that society has a stake at it. What is important to realize is that when we're at such a stage where people start to protest or are protesting, we're already a bit late to do something about how the technologies are being developed or being applied. Already in the very early phases of technological development, normative decisions are being made, like decisions with ethical and societal implications that will shape the technology, that will determine the risks and benefits, who will potentially use the technology and who might be excluded. So what we say in Utrecht and how we do our ethics research is what we call ethics parallel research. So like parallel to how the field develops, so the technology or the care innovations, we try to identify and evaluate which ethical implications might occur, these technologies might have. And that has the benefit that ethics is not too little too late, you know, that when the technology is already there, that the ethicist will point out, well, that you did not so right. And it means that when the technology is being developed and we identify and explicate these ethical implications, we can also still help to steer the development of technologies into desirable directions. Well, in the following 5 slides, I will just list 5 of the key elements that we have in our ethics parallel research. And we start with wicked problems. So, what is a wicked problem? It's something that is very complicated. And I love things when they're complicated. I mean, when it's easy, why do research on it at all? I mean, it's nice when it's complex and difficult. So what the thing is for technology is that there are so many different perspectives that have a stake or that have an interest in how these technologies develop, making it a bit blurry and complex and often also very unclear what sort of arguments we're actually talking about, because all the different stakeholders are having different opinions, making it like a very cluttered yarn piece. And what we do with ethics is then trying to disentangle again, like what are we actually talking about? And it can be just clarifying the questions, clarifying the concepts, or clarifying who is actually part of the debate. So that's the first element of ethics parallel research. The second part is that we actually always do ethics research from within, meaning that we always work together with the researchers at the bench or physicians, and increasingly more often also with data scientists when it's about research topics on AI or data. And that is important because we need to we need to understand what the technology actually is, how it works and how it can be applied, and how it's foreseen to be used in order to say something meaningful about it. Right? So if we are giving ethical guidance, we don't want to be led just by science fiction stories about the end of the world or the cure, the silver bullet for everything. We want to understand how these things work. And these are just a number of publications from our research group. Some of the people here actually have also published together with our group, and we hope that in the LifeTime consortium we will also work further together. A third aspect of ethics parallel research is that we look beyond the more hard impacts, so the very or relatively easy quantifiable outcomes, such as like economic impact or safety. We look at soft impacts, and that might sound a bit like a turn-off, as if it's not important, but it is. It is very important with these technologies. Especially these soft impacts are often a reason why societal stakeholders start to protest or are pro or against certain technologies. To give an example, for example, in the field of AI, there is a lot of research about the safety and the effectiveness, but in the end, a lot of societal questions are about the use, like will it replace my physician, and under which conditions will that be desirable? What does it do to the relationship I have to care providers? So this relationship aspect would be a soft impact. And as you can imagine, these soft impacts also make it possible to see under which conditions new innovations would be acceptable beyond mere safety and effectiveness. We actually almost always in all our projects do empirical research, meaning that we do interviews with patients or with the public, or do focus groups, for example. And we do that because that can be for several reasons. So when it's about applications that are already being used in the clinic, patients have sometimes knowledge that we as researchers do not have, right? So they know what it's like to be ill, what it's like to undergo certain treatment, and they can tell us what is important to us. So that can help in setting the priority on the research agenda. It can also be for mere instrumental reasons that patients can help to recruit other patients in research trials, or explain why certain measures are very burdensome to them, or simply for the reason because it's the right thing to do. It is research about them, so they should have a say on what is important to them. And then fifth, since a couple of years there's increasing attention for patient-public involvement in research. I think that is more general in medical research the case, so not only within ethics. But it actually means that patients or people of the public, like citizens, are involved throughout the research project and also have a say in how a research project takes shape, what the priorities are, who are being included, and how results are written down. So we have also published a number of manuscripts together with patients, which was really great fun and really meaningful, I would say. Right, so that was actually all I wanted to say. So this is sort of the method that we will also apply and follow in the LifeTime project in order to identify and evaluate the ethical and societal aspects of the LifeTime proposal, real time as we go. Thank you very much.
Thank you very much. I think it does give ground for thinking, and definitely the importance of developing this approach along with the project from the very beginning is something that we feel is really critical and that can make a difference. Let's see how we can continue. I think now...
about what type of diseases would we focus in LifeTime, and this is a main task of work package 6, the Launchpad work package, which is headed by Mihai Netea and myself. I'm Peter Lichter. And we have had quite some discussions, and we will have breakout sessions this afternoon, as you know, to go into more details on what would be the conditions for selecting diseases or disease groups and diseases, and what would be the procedure and the processes to implement that. And I would like to all invite you already now to come and join into this breakout session, everyone who is interested and wants to contribute to this. I think it's quite clear that we have to follow a very few parameters in this selection. One, of course, on the European level is the societal impact of a disease, the clinical feasibility and the clinical questions and demands that would make this necessary, but almost equally important, the availability or at least the potential for preclinical models, ex vivo, in vivo. We had the organoid discussions. That's why we are very close together with work package 5 on these discussions. And we will have from the 5 major disease groups that we think we should at the moment focus on, we have 4 of the topics selected for presentations. And here, again, it is, keep in mind, one has to get specific to bring across the clinical impact. But individual diseases we talk about so far are just use cases. It's not something that is already decided on. This will be done through the selection procedure that I mentioned. The disease groups so far that we had applied to in the successful application of the first phase of LifeTime were cancer, autoimmune diseases, neurological diseases, cardiovascular, and infectious diseases. And we have experts for 4 of them to present here. And without further ado, I would like to introduce for the first talk. It will be a bit longer because it's a split talk between 2 experts. So one is Mihai Netea and the other one is Jan van Lunsen. And Mihai, to put it short, came after his postdoc time back to Nijmegen, where he turned into an infectious disease clinical specialist. And he works a lot on human immune responses, innate immunity, sepsis, and immunoparalysis. And Jan is professor for internal medicine and infectious diseases in Hamburg, a specialist on HIV clinical trials and immunological research. And since 2015, he is a global medical director of VIIV Healthcare. So they will take turns. I will not interrupt in between. And then I hope for good discussions. Mihai.
Thank you very much. Thank you, Peter, for the introduction. Actually, I think this makes my life very easy because you already presented, actually, which is the objective of work package 6. And this is one of the first steps that we want to take into that direction, to develop the criteria for the diseases to be studied. Thereafter, a first selection of diseases, and a third objective will be a framework for the continuous addition of new diseases based on the developments in the field. Now, today, in this morning, I will just give you an example. And once again, there is no decision taken about the type of disease and so on, but the only thing that I would like to make the point, and together with Jan a little bit later, is that the approaches that we have discussed the last one and a half days or so, that were presented mainly in other types of diseases, such as cancer, are also very much applicable also to infectious diseases. And infectious diseases is a very important pathology, of course, because it's one of the most important causes of death. Of course, you would see here on number 4, but actually, if you see also later on number 9 and 10 are also infections. So if you add all of them, you get very close to what is happening with other very important causes of mortality, such as ischemic heart disease, stroke, cancer, and so on. There are many challenges to infections. So in the 60s and 70s, people thought, well, we are done with the infections. We have the antibiotics. What has remained are just some flukes of some small infections that we will eliminate very soon. But we could not be more wrong. There are major challenges due to infections, which mount now a resurgence due to the antibiotic resistance, which is spreading. You can see here only between in 5 years or so, the spread of antibiotic resistance in Europe. Also the globalization, the migration, spreading of infections is much quicker than it used to be. There are major pandemics, among which, of course, HIV pandemics globally. There are emerging new pathogens every time. Every decades we will have always, for example, influenza pandemics and so on. And we are using in the hospitals more invasive treatments which have an immunosuppressive effect on our host defense. So because of that, the number of infections in the hospitals, also in the developed countries, is rising. In the last 200 years, there were major successes for the treatment of infections, because infections were by far number one of the most important pathologies in human history. If we put together how many people died of infections, compared with all the other diseases put together during history, infections comes very easily number one. But hygiene, vaccination, antibiotic therapy, and later intensive care therapy for the very severe patients in the hospitals are the pillars which realized a dramatic decrease in the mortality due to infections. However, in the last 20 or 30 years, the mortality due to severe infections, even in very developed countries, did not decrease, basically. What is the next level for the treatment and infections? And we believe that only a personalized approach to the treatment of the patients can help us. And this can go into two directions: in personalized host-directed therapy, which is basically immunotherapy, but which should be adjusted to the needs of each of the patients, and personalized treatment of complications in chronic infections, for example, HIV. I will just give you an example, and unfortunately I see that something went wrong with my slides a little bit, but doesn't matter. Actually, what it has been done always in terms of immunotherapy, for example, for sepsis, which has been tried several times, tens of times actually in the last 30 or 40 years, to identify a pathway which is distorted in the patients with sepsis, and then treat all the patients with an immunomodulator. And there were many trials done with anti-cytokines, TLR4 antioxidants, and so on, which cost tens of billions of dollars, and which were all failures, basically. What it has been seen, however, is that this approach will never be successful. So we need a proper stratification of the patients, also with infections, like we do, for example, for cancer. Because sepsis in itself is not a disease, is not an infection, is a syndrome, and it is caused by many different types of infections, many roots, many pathogens. And for example, this is a study which has done stratification of patients based on transcriptomic profiles by the group of Tom van der Poel in Lancet Respiratory Medicine. And these are here different immunological and pathophysiological pathways which are differently modulated by 4 major endotypes of patients with sepsis. And when people assessed actually the mortality of the patients which are stratified based on these endotypes, you can see, for example, that one of these endotypes is much more, has a much increased mortality due to sepsis. And only through identifying the pathways which are responsible for the higher mortality in this small subgroup of patients, we can approach the disease through an immunotherapeutic method. So what we believe that we need to do in all infections, and I will move in a moment to HIV, that actually we need to do classifications, stratifications of the patients, either supervised based on immunological or clinical data that we have, but probably even better unsupervised classification based on omics approaches that would identify endotypes, and each of these endotypes will need to be treated differently through immunotherapy, and we believe that this is the only way to go further. Now I move very quickly to one example that I would like to give, and of course I cannot go in much depth due to time, but I would like to discuss with you briefly the case of HIV infections, which is a modern plague basically in some countries, especially in sub-Saharan Africa, the HIV positivity reaching 30%, but being causing a lot of problems also in the developed world. Fortunately, a success therapeutic story was available in the last 20 years when potent antiviral drugs against HIV virus have been identified. That being said, however, the mortality due to HIV remains higher in the patients infected than in the general populations, and we would like to decrease that and improve that. And what is one of the approaches that we think is necessary to achieve that? We have initiated in the Netherlands, together with collaborators from University of Bonn in Germany and from the Broad Institute in Boston, the Human Functional Genomics Project, which actually tries to understand the factors, genetic, non-genetics, microbiome, metabolome, and so on, which influence, on the one hand, the immune responsiveness of the individuals in health and disease, and on the other hand, how is that influencing susceptibility and severity of various diseases. And we have more than 10 diseases now being studied, but today I would like to give you the example of the HIV infections. And we started with a proof of principle study in 200 individuals who are treated with HIV, and in which we aim to identify biomarkers of viral reservoir, because unfortunately, even with the best treatment available, viruses still are able to remain alive in the body of the patients, and only the elimination of this viral reservoir will be able to cure, hopefully in the future, the patients, to identify the factors which influence also HIV complications, and subsequently to identify targets for diagnosis and therapy. So, how are we doing this study? And again, I think some things went wrong with some of the figures, but anyway, very simple. We do very in-depth phenotypic characterization of the patients, both at the clinical level and immunological level, and then we assess genomic, transcriptome, microbiome, metabolome, and epigenomic factors, which we try to intersect to understand how are the immunological responses and the course of the patients with HIV therapy, how is that taking place. And we do that at different levels, and I will give you the examples of these various levels. A first level is just, for example, to do one type of assessments and correlate that with complications, with immunological responses, for example. In this, for example, we have performed targeted proteomics of circulating markers and stimulated immune cells to identify the inflammatory markers which are associated with an active HIV infection. And this is just an example of the most important of these factors. In the same way, we can identify, and we have identified now, independent loci which influence the cytokine responses or the severity of the complications in these patients. We have identified metabolic factors which are influencing this, and so on. However, this is not enough, of course. We would like to improve the knowledge and what is happening in the HIV infection by combining this knowledge. For example, in such second dimensions in which we combine data sets, for example, we try to understand the correlation between different factors, correlations between different immunological factors, correlation between metabolic factors and immune system in HIV vaccinated individuals versus healthy volunteers, between metabolites and genetics in these individuals. And I will give you just one example. This is the correlation matrix. How, for example, immune cells which are stimulated with various pathogens which are very relevant for the HIV infections, how do these responses correlate with each other? And without going into detail, because we do not have time, you can observe, so these are various types of cells stimulated with different types of relevant pathogens for HIV infections. And we can see that, for example, there is a very strong correlation between the myeloid cell responses to various types of pathogens for release of pro-inflammatory cytokines, which is these are healthy individuals, and this strong correlation, however, basically almost disappears in the patients with HIV. So the normal networks of communications between cells at the terms of cytokine production, release of prostaglandins and mediators which make possible communication between cells is apparently lost or broken in the patients with HIV. However, we do identify suddenly novel associations and novel networks which are formed in disease, and we are trying to understand these networks. What are the factors influencing them? Are these networks important for the complications in these diseases? And we have some very exciting novel discovery that is the case. And a third level of trying to understand what is happening with HIV infections we are doing in collaborations with the colleagues at Limes at the University of Bonn, in which we try to combine these data sets that we already have also with assessment at the single cell level. So blood for all these individuals will be assessed both with advanced flow cytometry, but also both with bulk and single cell sequencing to understand also whether within the cell populations that we know are responding differently or have a disturbed network, whether there are indeed cell subpopulations which are very important in the disturbances which happens, and thus we want to integrate the immune functions with genomics, metabolomics, and FACS analysis and single cell sequencing. Finally, we want to combine all these data sets. For example, on the level of single-cell pathogen-induced transcriptome, to combine it with disease-causing genes, but also with metabolites, also with microbiome factors, with epigenetic assessments, to assess disease-causal networks, basically, which are disturbed in HIV, and thereafter identify the targets in which we want to go for diagnostics for patient stratification on the one hand, to identify the patients where these pathways are the most disturbed, and then for target identification. Of course, in this we also need much higher numbers than the 200 patients that we have employed in our first proof of principle study, and here we need and we have to team and collaborate closely to pharmaceutical industry, to big pharma, which has the capacity to help us to realize that. And for that I would like to invite my colleague Jan van Lunsen, with whom we started a collaboration now to do all these assessments, not in 200 but in 2,000 individuals with HIV infections, in which we want to identify these targets for diagnostics and therapy. So, thank you, Jan.
Thank you, Mihai. That was a fantastic lead-in to shifting gears now a little bit and show you the industry perspective. And I should say I feel very honored, and it's certainly a great pleasure to be here to speak to you from an industry perspective. I thank Mihai and Joachim Schulze for inviting me here and to give the opportunity not only to introduce what we're doing with the Human Functional Genome Project, but also how industry more in general looks at what you're doing and how that may play out in the future. Now, let me please start off and allow me to start with a personal note. I am a treating physician. I do treat HIV patients since 25 years. I shifted gears 4 years ago when I went to the dark side of the moon. But there are some bright spots there, so this is where I am. This is ViiV Healthcare, and the specialty of ViiV is we are focusing exclusively on HIV. We are a joint venture of GlaxoSmithKline, which is our major shareholder, and a little bit Pfizer, and later Shionogi joined in, and we are just focusing on HIV, so focus, focus, focus. And we are trying to actually bring in big minds and the brightest people from academia to join industry in this kind of biotech startup, which is embedded into a larger framework of big pharma. Now, having said that, what I'm trying to do now in the next 10 minutes is why are we interested in a cross-omics public-private partnership like with the Radboud University, and how may this fit into the LifeTime strategy? So let me start off by saying, that we can really treat HIV very well today, but there is no cure yet. And that comes with a lot of challenges with regard to lifetime therapy, cumulative toxicities, eventually development of resistance, but also cost and access is an issue. So we believe that a cure is mandatory and to keep on working on that, and cure is on the continuum of treatment. So if a patient comes to me today and I have to tell him that he or she is infected with HIV, we do have very many good options to actually treat patients. And basically, you can take one pill once daily containing only 2 drugs today in combination to really make a very successful and very suppressive therapy for a lifetime. You can even have perhaps tomorrow quarterly injections every month or every second month. We have actually within our 9-year history at ViiV, we have launched 5 products into the market against HIV. We have just filed the 6th one, which is an injectable, can be given every month. And we are aiming at another submission and filing next year. So this is an unprecedented success story. Why are we so successful? Because we're nimble and we're focused. And what is actually our ultimate goal is to cure HIV. But there are many barriers to HIV cure, and multiple barriers are just a few of them listed here. One, which Mihai has already alluded to, is the latently infected cell pool, or the so-called viral reservoir. You do have, and there's a lot of debate about that, subclinical level of viral replication. You do have anatomical sites which may not be approached by each drug similarly effectively, and you do have persisting immune dysfunction. Now, HIV disease persistence is largely driven by viral reservoirs. So our current therapies suppress successfully the production of viral RNA in plasma, but it does not have any good effect on the viral reservoir, namely the DNA, which is integrated into latently infected cells, do not respond very well. And here, this viral persistence is actually associated with chronic inflammation, and this chronic inflammation, we do believe, is actually driving a large part, at least in a good number of patients, what we call non-communicable diseases. So that is what we call immune aging. And these are the effects on the cardiovascular system, the endothelial dysfunction, dyslipidemia. NASH and metabolic syndrome is a big clinical problem, as well as end-stage renal failure and also metabolic diseases like frank diabetes to develop osteoporosis, etc., etc. So our patients with HIV are successfully treated in terms of viral replication, but there is some immune activation persisting, which we believe is due to the fact there is viral persistence and release of viral proteins, okay? So HIV hides in long-lived cells and also in tissues. And just to set the frame here, it is that latently infected cells, which are here in green, you know, retroviruses integrate into the genome, and then, you know, once it is integrated and the cell divides, it will you know, pass on to the daughter cells, of course. So this is what we call homeostatic proliferation. So even in the absence of active viral replication, just by division of infected cells, the reservoir will be replenished on and on. And it has been a long-standing dogma over the past decades that retroviruses, as HIV, will integrate randomly. This is not true, and there is one of the champions of this integration site analysis here in the audience, Monsef Benkiran, showing that, you know, the fate of a cell and the cell activation pattern of a cell and the genetic pathways which are turned on when the cell gets infected will pretty much determine where these retrovirus will integrate into the genome. So this is a strong link to the cell level which you are studying. Other problems which we are facing is that what I call the macro compartments. So there are different cell types which are infected. Usually it is CD4 positive T lymphocytes, and the latent reservoir made in the great majority consists of naive T cells. But we do also know that in the brain microglia are infected and that there are T follicular helper cells in the lymph nodes play a special role, gut-associated lymphoid tissues play a role, etc., and the genital tract, of course. So we do also have macro compartments which are playing a role. So what we do have very well established is depicted here on the left side. We can treat hopefully early as diagnosed, restore immune function, prevent AIDS, and improve the life of our patients. And clearly, in the vast majority of patients who are diagnosed early and treated well, we can really treat them as good as reaching them a normal lifespan. But there is, on the host side, much to do. We do have persisting chronic activation and inflammation. Therapeutic options are needed which target now host responses and host factors to enable more efficient immune functions, also to control HIV infection in the future with less interventions and lower the reservoir, and eventually and ultimately hopefully allow us to reach a cure. So that is the first 5 minutes of my talk. The last 5 minutes I will spend on giving you an industry perspective in general. Big pharma investments in 2018 for the first time exceeded $100 billion in 1 year, okay? And you can see this is the annual growth rate, which is about 6%, and it increased from 2012 to 2018, as you can see, by 32%. So there is a steady increase, $100 billion investment each year, and a steady increase in these investments. Now that led to a record number of innovative medicines which were launched in 2018, bringing 59 new treatment options to patients. And here in the circles you can see the therapy areas. And what you can see is 27% come from oncology, and then followed by 20% infectious diseases. So oncology and infectious diseases and neurologic diseases are actually drivers here in this investment, okay? What you can also see is that half of those are in rare diseases, in so-called orphan drug designations, and we do see already 1/4 not being small molecules but being biologics now. A part of them are actually either stratified and diagnosed and with kind of predicting response by predictive biomarkers, and then you do have a number of other compounds as well. Now, new drugs launched in 2018 took an unacceptable 14 years on average from filing of the first patent to the launch of a product. 14 years. And this 14 years is not only hard work and taking much too long, but it's also very costly, okay? Now, what I've shown here is also that, you know, there is a large variability. There are some drugs which have actually taken 30 years for tafenoquine, an antimalarial, to develop into the clinic from the first filing of the first patent. This is unacceptable. What is the contribution of biotechs? Concentrate on the right side here, please. In 2018, These are the new drugs which actually originated from small biotechs, which eventually were launched later. And at the originator, in 2/3 of those products were actually biotechs. And then they moved on to develop these drugs, you know, in collaboration with Big Pharma, or Big Pharma bought the biotech, so that it turned out at filing that it was almost equal, you know, from Big Pharma and the distribution and biotechs at the time of filing. The next generation biotherapeutics have more than doubled since 2015, and all of these different disease areas have actually contributed to that increase in biotherapeutics. But again, as you can see here in green, the darker green, infectious diseases do contribute also to this field of increasing biotherapeutics to develop. Now, the composite success rate of clinical development stages from phase 1 to launch actually fell to 11% only. What does it mean? If you develop 10 drugs or file 10 patients, only one will make it into the clinic. And what you can see here is the likelihood on the bottom here, the likelihood of failure in different stages, or here, I shouldn't say failure, but success, so is the glass half full or half empty? In this sense, it is half full. And what you can see here is the attrition rate between phase 1 and 2 is the biggest, of course. But again, if we could only make it a from 10 to 20% success rate, for us as an industry, this would be an immense save. And it would be an immense return on investment if we could make this happen. So let me end up by giving you one of the perspectives. I'm now head of translational medicine at ViiV. I thought translational medicine means from bench to bedside, but also bringing the real problems from the bedside to the bench. But this is not my real remit. My real remit is actually to be translating language of academia into industry language and vice versa. Your language in academia, my language in academia, let me take one expression, currency. What is the currency you're paid in? Your currency is impact factors, successful grant applications, reputation, and maybe awards. Our currency we're talking about is return on investment, shareholder value, and basically increase in growth and sales. Okay, that's our currency. So here we need to find a real good partnership to increase these PPPs. We do believe that genetically validated target identification is crucial to identify as well better biomarker algorithms, either for the selection of the right patient population or also for allowing us to assess if our medicines are working well or not so well. We have to minimize by doing that to this attrition rate, which I have showed you. We have to create funds to help the transitioning from discovery to early development and to enable a higher success rate in early development stages. And we have to use, ultimately, innovative trial designs, ensure early alignment with regulatory bodies, of course, and account for moving towards from small molecules to biological and biotherapeutics, and ultimately transition to more precision and personalized medicines. And my last slide is some words of wisdom for success, and I have borrowed this slide from my colleague Ray Shinazi. Ray developed a couple of very successful drugs, including some drugs for HIV, but also for hepatitis C, one of them sofosbuvir, so he knows what he's talking about. And his words of wisdom and my words of wisdom is know what is wrong with your drug before someone else finds out. That's number one. Number two, if you're going to fail, fail fast. This means you have to aim high and fail cheap, all right? And then you are not a failure. It's the drug which is the failure. You have to be trying, keep hard, and work on. Doing nothing has consequences. Don't just sit and wait, do something. Make every experiment count towards an IND or NDA filing and put the patient's need at the center of what you're doing. This is ultimately what we need to really focus on. And this is, I believe, the most important message from me to you today. Choose your collaborators wisely. Having great collaborators who deliver is critical. Thank you very much.
Thank you very much. I particularly liked your term, you're successful treating patients through lifetime. Right?
Yeah.
Yeah, I mean, maybe I can ask for a general view on preclinical models. from the big pharma, do you think to, as you said, to stop fast, to fail faster would help us? Is much more needed on the preclinical level in your view? And if so, the question to Mihai and to both of you on the HIV, how much do we have any preclinical models that could help?
You want to start or me? Or?
Yeah. You have to come here. So there are some clinical models. Of course, simian models probably the best, some mouse models in humanized mice also. But I do think that actually human immunology in the case of HIV is by far #1. And of course, the experimental models could help for very specific questions.
I agree. It always depends on the question you have. So if you want to study toxicity, sometimes, or even pathophysiology, mouse models would be great. But if you ultimately would come in now with something which is immune response modifying, for instance, the mouse is completely different to the human immune system. And by the way, to infect the mouse, even a transgenic mouse which is repopulated with the human immune system is not meaning that this is a normal human immune system. So I doubt that this will be a real good model. Even what we have learned in the past, using simian models like macaques, chimpanzees almost never. The chimpanzee, by the way, is a very interesting model because HIV is the chimpanzee is the only natural host for HIV, but the chimpanzee doesn't get sick. So if we could only understand why, that would help us a lot. So there are some models, but I'm a big believer. Don't waste your time too much with monkey and with mouse models. Go into the humans. Go to people like Mihai and his group, and try to find out what are the determinants in the human system, and take it from there.
Okay. Thank you for the beautiful talks. I haven't heard anything about vaccine.
Yeah.
What you, Mihai, just presented. I think applying that to understanding, vaccine response, immune response to vaccine, I think would be just wonderful, because we know that we need vaccine for HIV, and if we achieve a good vaccine for HIV, I think we will be able to easily make vaccine against many other infectious diseases. What do you think?
Well, I cannot agree more. Let's put it very simple. And I think that understanding indeed variability in the immune responses in the human host, understanding why some people are, for example, resisting to the infection with HIV, why some of them are rapid progressors, and so on. And this is one of the aims of what, because of the time, I didn't have the time to present that, but this is also one of the aims that we have. Understanding that will greatly help us also in vaccine development, and actually, certainly, HIV, I do think that is one of the more difficult vaccines, so that would help also for the other infections.
Absolutely. Yeah, I couldn't agree more. And, as Mihai said, looking at the outliers of the Gaussian shape in this, human functional genomics project will help us to understand the correlates of immune protection, for instance. And this is really needed, and as well as me that there is a hype about BNAPs and using these broadly neutralizing antibodies as an epitope scaffolder and all that stuff, but I think what we got to do really is to really understand why these rare patient phenotypes do exist, and if we do come across why these rare phenotypes actually, and how these people and individuals make it happen, that they can control the virus without any intervention, I think we are a big step further.
All right. I think, as I don't see any point at the moment, and also for the sake of time, even though preclinical models is something we should keep in mind, I think, to further discuss maybe this afternoon in infectious diseases, I would like to present the next speaker, Bart Stoper. And he is professor of molecular medicine in Leuven and scientific director of the Dementia Research Program of the University College in London. And his activities are fundamental mechanisms in Alzheimer's and Parkinson's disease. And thank you very much for coming and sharing your views with us.
Thank you very much. So it's really exciting to hear about the successes in other disease domains, and it gives me hope that at a certain moment we will be in the same game with the disease which interests me, which is Alzheimer's disease. But I would like to see the slides projected Is it possible to project the slides? All right. Okay, so, well, I'm representing quite a lot of organizations. As said, I'm leading the Dementia Research Institute in the UK, which brings together from 6 different universities efforts to do something about these disorders. And I have also appointments at the VIB, UCL, and KU Leuven. So, just to put it in perspective, I think that dementia is one of the major health problems in the world. And first of all, because of the numbers, and here you see the expected increase over the next 20 or 30 years, which will result in 135 million patients suffering from this problem worldwide. And second, different from other major diseases, it's the only one for which there are no therapies and no hope for the patients at this moment. So, when people ask me why is it, well, I think that it's huge underinvestment and a long taboo on these disorders. And so I compared the output or the scientific knowledge we have in different fields of disease. And so here you see the number of papers published per year in the field of AIDS and HIV. And we have at this moment a steady state of about 7,000 papers a year. And here you have the numbers for Alzheimer's disease. So you see that only in 2016 we reached the same level as the AIDS field. And you can also see from the area under the curve that we have about 30% to 40% less knowledge about Alzheimer's disease than about HIV. I think that the crossing of the line is largely explained by the investments in the United States, where there's really a big effort now to tackle these disorders. Everything dwarfs, of course, when you compare it with cancer. So what is Alzheimer's? First, what is dementia? Because both are confused usually. So I show you here some, instead of a clinical explanation, some painting, some art, it's sometimes nice. So this is William Uttermolen, who painted himself in '96, and he got Alzheimer's disease. And over the years, he continued painting himself, and I think this says much more than many words. Dementia is losing your mind, basically. Dementia is a symptom, and there are many causes of dementia. Alzheimer's disease is, however, the major one. So about 60% of dementia is explained by Alzheimer's disease. But there are several other diseases which have similarities with Alzheimer's disease, and that's why we study all these disorders together in one big institute in the UK. So what's the cause of Alzheimer's disease? Well, the first thing is that it's a proteinopathy. So that's different with viruses or with cancer or with other disorders. Here it's really proteins which cause the havoc. And so Alzheimer's disease is characterized by protein aggregations called neurofibrillary tangles, amyloid beta plaques, which are extracellular tangles, are in the neurons, and then there is also amyloid deposits in the blood vessels. And a second important aspect is that these proteins, also in the other neurodegenerative disorders, spreads over the brain. So they start in specific localizations, and then they go over the whole brain. So it's a kind of internal infection or internal metastasis, but I don't think that these analogies are very helpful. It's a typical signature of these diseases that it spreads progressively over the disease, over the brain. So there are 3 causal genes. We are starting to get better and better understanding of these disorders, and I'm limiting myself to Alzheimer's disease. There are 3 causal genes found for Alzheimer's disease. It means if you have a mutation in that gene, you get the full spectrum of Alzheimer's disease. And so the first gene is the amyloid precursor protein. It's a simple protein, and if you have mutations in it, you get an A beta cleaved out of this protein, which precipitates in the amyloid plaque. So there is a direct link between the morphology of the disease and the genes causing the disease. And so all the mutations are clustered around this amyloid peptide. The second gene, or the second 2 genes basically, are parts of this large enzymatic complex, which is the gamma secretase. There are more than 170 mutations, independent missense mutations, which cause Alzheimer's disease. And the interesting thing is that this is a protease which cleaves this amyloid precursor protein and gives rise to this amyloid peptide. So shorter forms and even longer forms when there are mutations. So one of the big conundrums in the field at this moment is, if mutations in the enzyme and mutations in the substrate invariably give you Alzheimer's disease by increasing amyloid peptide, why is then that medication which has been developed does not work? And so I think that one of the major insights is that we forget the time factor in this whole problem. And so here you see a typical graph where this is the accumulation of amyloid, and then you see the different other manifestations, tau accumulation, memory dysfunction, clinical dysfunction, which follows. But the important thing is the time factor. And so we know now that this blue arrow takes 20 to 30 years. So people are look completely healthy, have no signs of dementia, but there is already accumulation of these proteins. And so at the moment, we are studying mainly this last phase, which is the clinical phase, which is like we would study cancer at the time that you are completely cachectic and metastatic. There is no cure for that type of disease, or AIDS when you are completely at the end of this end stage. And the field has been largely focused on this end stage because that's the clinic. On the other hand, we have the biochemistry. But as I told you now, this is 20 to 30 years before you are there. And so this is the critical phase. What happens in the brain? What homeostatic mechanisms are you disturbing? What are the cells doing in the brain so that you can keep thinking while these proteins are accumulating? And what finally makes that this homeostatic phase gets disrupted? And so this is just to show you that this is not a linear process, but with feedback loops, and it's a multicellular process. So there are, of course, the neurons and the synapses which degenerate, but you have the glia cells, the oligodendrocytes, the microglia, the vasculature, and probably also the peripheral immune system, which plays a role in this process. And in that sense, we are finally ending where cancer is already a couple of decades, I guess, understanding that these are multifactorial, multicellular processes, and that you need a a box with multiple medications to target these disorders in an effective way. So how do we study the cellular phase? And again, it's the genes, stupid. You will hear a lot about environment, etc., because that's easy press. But there is an important twin study, and there are not enough twin studies in our field, but this is really a big one. And this study comes to the conclusion that between 60 and 80% of your risk to get this disorder, to get Alzheimer's disease, is genetic. So it's in your genetic makeup that the risk is present. And this is the sporadic cases. So the 3 mutations I told to you are familial cases where you have a dominant inheritance. This is your chance as a person to get sporadic Alzheimer's disease. So over the years, there are more than 1,000 genetic risk loci now found in sporadic Alzheimer's disease. And this is classical, the Manhattan plots, which most of you know. So you have here the different genetic loci in the human genome, which in combination determine whether you get Alzheimer's disease or not. And so you can look at a high cutoff, which is usually done, so then you get about 20 or 30 genes with high risk. And then you can also take a low cutoff, and then you find thousands and even more genes, or gene loci, which are associated with the disorder. And so then we can use these genetic risks by combining them in what's called a polygenic risk factor. And if you use the major genes, you get a prediction strength, which is indicated by this curve. But if you add even the low risk, the low p-value risk genes, you still add to the predictive value of this model. So if you combine the different genetic factors in these cells or in these humans, you can predict to a good extent your risk for Alzheimer's disease. So that tells us also that mechanistically, in this genetic information, there must be a way to find the mechanisms and to identify new drug targets. So how do we use this genetic information to generate functional hypotheses? I think that's a real question. How and under which conditions will genetic risk manifest? And that's really a very important concept. So it's not equal where you test the function of these genes. It's a bit like when you drive a car and you have your belt on. It's a risk factor if you don't take it, but you will never know that it's a risk factor until you had your car accident. Well, you need to think about these genetic risk factors in the same way. You need to test this function of these genes in a disease-relevant environment. Can we investigate these risk genes in pathological relevant conditions, as I explained? And to what extent, and that's really also a big question, is the mouse a good model to study these polygenic risk scores? Because, of course, the context in which these genes manifest is not only the disease context, but it's also the rest of the human genome which determines how this genetic risk manifests itself. So one thing which we terribly need, I think, in our field is to go away from the classical pathology which we use to describe the disorders and go to and to really use the strength of modern technology to get a full picture of the molecular changes in the brain over time and over space. And this is just to illustrate this again for it's Heiko Braak, basically a pathologist, who described how amyloid distributes over the brain and also how these neurofibrillary changes change over the brain over time. And we need really to document not only in a morphological way these things, but at a molecular level. And so here you see a proof of concept study from my lab where we use spatial transcriptomics and a mouse model with knock-in of the amyloid precursor protein mutations. And what we did is we analyzed this mouse at different stages of disease, so from 3 months to 18 months old. We took a slice which we analyzed with spatial transcriptomics. We took a slice where we did histological analysis, and we added this information, we integrated this information in a kind of atlas of what happened there. And so one of the things which interested us very much is what happens around these plaques here that I'll show you in the next slide. So you see here these amyloid plaques spreading over the brain over time, and you see also the cellular response around these plaques which changed dramatically. So we developed a bioinformatics tool to measure how close our spatial analysis was with the plaques, and I have no time to explain that, but we have an automatic way to measure the amount of plaques and how close they are to the genes we are investigating. And then we took more than 10,000 different spots in the brain of these mice to see, to analyze the genetic composition. And as you can see, to our delight, these spots cluster according to specific anatomical regions of the brain, and they also cluster according to the time that they are exposed to amyloid plaques. So we think that we have really good data there. And so here, just a very short overview of the potency of this type of analysis. So we have here an analysis where we have two axes, the amyloid beta load, so the plaque load in the brain, and here the genotype load. And you see at 3 months that we have quite some genes changing according to the amyloid index, so genes down, genes up, and here genes down and genes up. But you see how this really dramatically changes at 18 months, and where we have a whole bunch of genes which change according to amyloid load and genotype. And so by analyzing this type of genes, we can identify novel pathways and understand how the brain reacts basically to these plaques. And here you have an example. So here you have a group of genes which is clearly up early at 3 months, and they're all in the oligodendrocyte, so a cell type which is usually not thought about when you think about Alzheimer's disease. And these oligodendrocytes generate myelin and are very important for the wiring of the brain. So you get a kind of reaction at 3 months, which goes then completely down at 18 months of age. And we can quantify that over the brain regions with the spatial transcriptomic approach, where you see that at 18 months, this response is largely gone and is only present still in the hippocampus. We have also an inflammatory response here, which is not high at 3 months, but which becomes extremely high at 18 months. And you can see here in red the brain areas where this response is located. So the problem with mouse studies is that there is a limited orthology of genes, and we estimate that about 30% of mouse genes, 30% of human genes are not reflected by a good ortholog in mouse. And so that's probably one of the reasons why mouse models are limited in value when you try to model complex pathways. And so one of the things I mentioned also in my intervention a little time ago is that what would be extremely helpful to get this genetic information from patients, this polygenic risk score from patients, a tool to study that are iPSC cells, because you derive them from the patients, you have the full genomic information, you can take low risk, high risk, and you can start to do all kinds of experiments. So one of the things I would like to set up in UK and hopefully also in Europe is a huge database of material of IPS, of patient data with genomic data and with clinical data, associated with large cohorts, and to give the scientist the possibility to get access to blood or to cells and to make iPSC cells so that they can study specific genotypes and look what the phenotypes are in the models. And then here, the model which we use a lot at the moment, and it's really a breakthrough, because at the moment we are hesitating about organoids as such, because they are largely embryonic and developmental relevant, but not really relevant for a mature brain. And so we have found a kind of intermediary solution at the moment where we transplant iPS cells in mouse brains and see what happens with these human cells. And here you have a human neuron in such a transplant, so they really reflect nicely human cells. Here you see astroglia, which we transplanted, and they keep this very nice morphology, which you also find in human context. Here, for instance, you see an astroglia which wraps a blood vessel in this mouse brain. And here you see that they react differently to plaques. So these blue things are amyloid plaques, and you here see an astrocyte which heavily react, which is hypertrophic. And then here you see an astrocyte which react in an atrophic way. And then there are, of course, also astroglia which do not react. And so it will be fantastically interesting to see how the GWAS genes in this astroglia respond and modulate these responses. So we have also a lot done on human microglia, and this is really cool because they work very well. If you delete the mouse microglia, then the human microglia are sitting in exact niches where the mouse microglia were present. We compared also with single cell analysis whether this mouse microglia reflect human microglia, this iPS-derived microglia compared to primary microglia derived from patients, which we got brain sections from patients who had epileptic seizures and who got operations for that. We got healthy pieces of that brain, isolated the microglia, and we did single cell, and we compared our preparation with each other. Here you see summary. The only important thing here is the in vivo signature of homostatic microglia. Here you see what happens with in vitro generated monocytes and microglia, and you see that the in vivo generated microglia very similar to the primary microglia we isolated. And so here you see an experiment where you see the response of human microglia transplanted in a mouse model for Alzheimer's disease, and here you see the mouse response. It's very different, and so I think we are opening a box here for further research. I can skip that slide. Just a mouse microglia give you this, human genes or orthologs, and a human microglia give you this. So what are the most important hurdles in dementia research? For me, compare gene effects at the whole brain level and with single cell resolution, genomics, transcriptomics, but also proteomics. It's a protein disorder, allowing unbiased biomarker discovery, develop in situ methods to access spatial resolution, and then on the long term, we need better models. In vivo human-mouse hybrids are really revolutionizing the way in the way we do neurodegenerative research. But on the long term, we need 3D derived cultures refined at organ level, brains in a dish, integrated with probes and with measurements in situ. And we need also specific models like blood-brain barrier or glioneuronal unit. This is less important for this conference. So just to say that I think that we need to enhance, to get also the proteomic work into these approaches. I just heard Matthias Mann talking about single cell analysis of proteins in brain, and I think that's really one way to go. And that's here then what I think about organoids. We need to get much more complicated systems which allow us to program the cells in situ, which is possible with these chips, and which allow to let the organoids grow in 3 dimensions, so where the scaffolds give you the way to feed your 3-dimensional structure. And so conclusion, the problem in the field is a narrow portfolio of drugs, so we need to find new drug targets. I think I showed you some way. The clinical endpoints are based on cognition, which is completely wrong. We need upstream and measurable biomarkers. And then we need to get much better data science to pool all the information available. So thank you very much.
Yeah. Thanks for this beautiful talk. In your last remarks about the organoids, what do you think is needed? As you said at the beginning, organoids are good for embryonal development, cell lineage. it might be difficult for degenerative situations. So what do you think would be the angle to?
My approach is a parallel approach. So we are using now this transplantation, which gives us a lot of information on how these iPS cells change in a three-dimensional structure. And I would like to use that type of information as a kind of guidance while we develop this three-dimensional cultures. And so I think the secret there is to provide them with the right substratum, which needs a lot of investigation. I think we should profit while making that right substratum from engineering technologies to bring electrodes into the matrix and bring also small nanochannels into this matrix via which you can transfect your cells. And so you could start to think about induction of your iPS cells in the type of cells you want. And in the long term, the rest I cannot predict. I hope at a certain moment that the cells are very similar to primary cells from brain.
There are people lining up. We start.
I also forgot one thing which is very important for this endeavor. So access to human materials is in the UK really remarkable. There is a brain bank of thousands and thousands of brain frozen, usually with good quality. There are 500,000 samples in the biobank with all genomic material, and they have 10 or 15 cohorts which they follow already for decades, and where you have also access to materials.
You're talking about autopsy.
I'm talking about autopsy.
But during the biochemical phase, this might be
it's less
very
good.
difficult.
So that's why we need these animal models.
Yes.
Thank you very much for that fantastic talk. So my question goes very much with your last comment. Also on your slide, you show the importance of creating disease cohorts and how important it is that they are well characterized. So I wonder whether you could give us some perspective on that, because we have learned how strong bioinformatics has developed, how precision techniques are developed, but I feel that most specimens, even if you have best frozen materials in the UK or so, still the clinical data are sometimes really, let's say, by and large suboptimal. So you're fishing in muddy waters here, and maybe Geneviève and Nikolaus may also kind of comment on it. How do you want to include this kind of building up of cohorts into your consortium? I think this is very important.
It's the Achilles tendon of the whole operation here. There is a big discrepancy in the culture of the clinic and of the research, and it has to do largely with the respect for the privacy of the patient. So, and we all know that if you open the database and you give somebody genetic information, then basically the anonymity is gone. So my approach would be, first of all, there are already very good cohorts in the UK where they follow people from shortly after World War II up to now, and they have consecutive clinical records of these patients, and they have also still access to these patients. So I think with good discussion with these patients, you might get access also to iPS cells and blood, etc. So that would be one of the first ways to go. Second, I think that could be expanded to several other diseases, where you say, look, with LifeTime, we decide to support a cohort in that country for that, a cohort in that country for that, a cohort in that country for that, and we predefine how data will be shared. So everybody who participates in that cohort knows that that will be used for open access under certain ways of secrecy, etc. I think that's feasible. I think the reverse, to get access to huge databases which exist in the clinic, will be, I think it will be Sisyphus labor. So you will roll the stone up and it will turn down again.
We have to look a little bit after time. We have 3 more questions. Nikolaus first.
Yeah, so first of all, thanks for sharing these data and conceptual perspectives with us, and I think you must be aware of it. Your data about Alzheimer's saying that it goes back, maybe 20, 30 years, and it's about finding, this progression early on is exactly the LifeTime paradigm. Also thanks for mentioning Matthias Mann with the proteomics. He's actually an active member of LifeTime, so I think there will be more of this in the future. But here's my question. So how far back do you think really goes the divergence of disease to healthy in the Alzheimer familiar cases?
This is really a very funny thing in the field. Everybody says familial Alzheimer's disease is not related to sporadic Alzheimer's disease, and we have been focusing on the wrong problem. Is that the question you asked?
No, the question is about the time scale. So you said it starts 20, 30 years earlier, but maybe it's 50 years, right? So
yes.
How far do you think does it go back?
I think for familial Alzheimer's disease, it's present from birth. So you have the genetic bomb in your genome.
But do you see alterations in the biochemistry of the cells early on, you think?
So the best studies are with the familial Alzheimer's disease cases where they did imaging, etc. And so that's 20 to 25 years before you get the symptoms of dementia. The official symptoms of dementia that you can see already amyloid plaques and
because what people see in the organoids built from patients with familiar Alzheimer using controls where this mutation is cured is very early already alterations. So there are all kinds of complexities to this, but maybe it goes back much earlier than maybe you even think.
I think a parallel approach is certainly indicated, but I would be very hesitant to look. I'm 59, so I think that organoids will deliver in 10 years, and so I don't want to wait 10 years to do further drug development and trying to understand mechanisms. So I will keep my eye open and I will stimulate that in my institute. But I think we need to go parallel. We cannot wait 10 years until the organoids work for doing this type of research.
Yeah. Okay, second last over there.
So your point of that over here, the gamma secretase inhibitors and the other inhibitors are not working is that because you're using them too late, right? So have you tried in your mouse model where you can go into an earlier stage and say, do we have an effect of gamma secretase inhibitors and the other inhibitors in that mouse model to see where is the right time to really do the treatment?
This is the conundrum. So the mouse models are good amyloid models, but the cell reaction on this amyloid is different from what the human cells do. That's why we are developing this. So we didn't do that type of experiment yet with the chimeric mouse model. So in the mouse models, you get a complete cure of the disease, but they are indeed only made to make amyloid. So, so that's a limitation.
Okay, last question.
I would like to comment on the most earliest phenotype on cells, which you see the oligodendrocytes. Is it right? This was also shown for the Huntington's disease also this year from Michael Hayden, and this is also seen by us in spinocerebellar ataxia type 3 mouse when we screened the proteomics of the mouse all over the disease progression. But my question is, would this also be due to the mouse background? Because it's
these are we don't know.
It's a bit suspicious now. I got a bit suspicious when I saw.
I think I just got excited. Well, I knew this already. So the microglia response is also shared by many. It's like in cancer. You have some concepts which are shared. So all these diseases have abnormal protein accumulations, and they are all killing neurons. And so the reaction of the tissue on this general principles will be somewhat shared. So there will be differences, but there will be shared aspects. And I think it's very exciting to see that these oligodendrocytes are part, I think, of a protective mechanism.
Yeah, we see the early phenotypes on proteomics in 2 months old animals, for example, but don't see the transcriptomics on these animals. So like the proteins are first in our case, spinocerebellar ataxia type 3.
Okay. Thank you very much again, also for this very extensive discussion. So I ask Georg Schett to the podium from the University of Erlangen-Nuremberg. He is a very active translational and clinical researcher on the pathogenesis of rheumatic and immune diseases, and we ask him to share his view on chronic inflammatory diseases. Thank you very much for
thank you for the kind invitation. I have seen a very stimulating talk before, and Mihai, Jan, and Bart have actually alluded to the common problems and challenges of the diseases. we want to tackle, and also about the ideas how to overcome them. So I am one of the rare species of physician scientists, and I think they are more and more dying out recently, and I think that's also a challenge for life research in the future. So we have to try to basically intermingle much more clinics and molecular sciences in inflammation and in other fields of disease. So I have 20 minutes of immune-mediated inflammatory diseases, and I want to give you a kind of a 10,000 miles overview where the field has developed and what are the key challenges at the moment. So the inflammatory response is crucial to us. It's actually a physiological response. Whenever you burn yourself, you cut yourself, and you have an infection, you have to overcome this problem by an inflammatory response. But at the other hand, you have to also resolve the inflammatory response. And it's a very tightly regulated process, because otherwise we would all get inflamed forever and we would die early when we wouldn't resolve inflammatory responses. There are several factors, crucial factors, which make an inflammatory response to an inflammatory disease. One is autoimmunity, as you see here. One is genetics, and the other one is barrier dysfunction. If inflammation becomes chronic, you develop these kinds of diseases, usually at the inner outer surfaces of the body. Rheumatoid arthritis, Crohn's disease, asthma, but also psoriasis are the typical features. They come early in life, they are very chronic, and they destroy the tissues. They have a huge impact on the life quality of the individual patients, but also for the healthcare system, because usually treatment has to be given lifelong, and there is yet no cure in these kind of conditions. So when you look at the textbook, we still live in the Stone Age, I would say, of inflammatory diseases. You see these galaxies here in colors. This is the vessel galaxy, the joint galaxy, gut galaxy, skin, lung, eye. So they are in all the hospitals in the world. These are usually the departments of medicine. So patients with these diseases usually come to a specialty, and they are treated based on a symptom, a clinical symptom-based approach, which is actually more and more an old-fashioned approach, I think, which has to be overcome. Why I say that? Because what we have learned is that we have in our hands nowadays a multitude of targeted immunointerventions, as you see them here, usually targeting different cytokines, but also mechanisms of the adaptive immune system. And actually, we learned about the diseases from these therapies. So there's actually a complete reverse translation. Prediction from animal models were 90% wrong, and actually clinical studies told us how these diseases actually work. And the result of this is actually two learning things. One is that there can be a very different appearance of a disease in one or the other organ, like this coffee machine and the car, but they are actually fueled by the same principle, by the same cytokine. And the other learning point is that there could be very similar looking disease, for instance, affecting one organ, but they are basically fueled by completely different cytokines. And based on these lessons, you basically now could, and in textbook you still don't find it, you could go for a mechanistic molecular-driven tree of these inflammatory diseases, which are pathway-oriented, and you can see all these colors are now intermingled, because actually pathways do not look so much for organs. They drive a process in different organs, and I think that is what we learned also from cancer very much, and this is now also in inflammation, that you basically look for molecular patterns of pathology which are driving disease process. So where does the field move? Actually, it moves in whole medicine now from a more symptom or clinical pattern to a molecular pattern. A typical example is breast cancer, which is the standard nomenclature, but you now can also speak about, for instance, HER2 positive cancer, because it's also cancers in the stomach and in the ovaries, which are HER2 positive. And you have a common principle, the epidemial growth factor type 2, which you can target with trastuzumab. So trastuzumab does not only work in breast cancer. Same for CML. CML is known to be Philadelphia chromosome positive tumor, but also others are positive, like gastrointestinal stroma tumors or mastocytosis, for instance. And there is a common mutation, BCR-ABL mutation, which you can target with imatinib, for instance. But this concept also now translates more and more to immune-mediated inflammatory disease. A classical example is Ormond's disease, rare disease, which is an aortitis of the abdominal aorta. And it's now known that it's actually an IgG4-mediated disease, and many other diseases which were in the textbook that were not known why they actually, how they work. For instance, thyroiditis, certain forms of thyroiditis, and certain forms of pancreatitis, not the alcohol-induced pancreatitis, actually all related to this IgG4. And we now speak about, we label this IgG4 syndrome, and we have a common pathology which we can target now with a adaptive immune intervention targeting, for instance, B cells. So there's an enormous flow nowadays in inflammatory medicine towards a molecular disease nomenclature. It all has been instigated by cytokine targeting, and TNF targeting is actually the prototype of a successful treatment of inflammation, modern treatment of inflammation. And it was quite interesting that TNF targeting actually targeted several different diseases, so it's basically a kind of a key fuel for several inflammatory diseases in the eye, in the spine, in the gut, and also in the skin. But we should not think that it works for everything. And this is shown here. We usually consider glucocorticoid, for instance, work for any kind of inflammation, and the same is for TNF inhibitors. But that's not true. When you look at different inflammatory diseases, yes, you can find them where both work, like, for instance, in rheumatoid arthritis. But you can see diseases which are actually inflammatory diseases which are not glucocorticoid responsive, like psoriasis, which are very TNF responsive. While there are diseases like asthma, which are very glucocorticoid responsive, but not anti-TNF responsive. So you can see that there's very distinct, actually, responsiveness of the different inflammatory diseases towards therapy. What is also important that cytokine biology in the last decades has learned why inflammatory diseases are creating pain, why they create depression, because cytokines bind to peripheral neurons and elicit a stimulation of the brain, not only at somatosensoric areas, but also at the limbic system, which actually can now be interfered very well with cytokine inhibition. We call that also the feeling better effect of certain drugs, which I think we don't understand that well, but it's a clue to understanding better these diseases. With more modern anti-cytokine blockers, and you see here a list of them, you can see that you even are now much better in fingerprinting different inflammatory diseases. And you can, for instance, see even in a certain cluster of diseases, the eye is only responsive to TNF blockade, the gut to TNF and IL-23 blockade, the spine for TNF and IL-17 blockade, and the skin for all of the three, while, for instance, IL-6 and IL-1 blockade does not work in any of them. So you basically, with your therapy, you can fingerprint diseases, and you allow basically a new understanding of these kind of condition. And even within a certain organ, like in the joint, you can see that there is actually a very differential responsiveness to classical drug, but also to the newer drugs. The only one is TNF inhibition, which is actually working in all of them. But look at these ones, actually very different responsiveness to certain cytokine inhibitors. So basically, these experiments, these human experiences, teach us how immune-mediated inflammatory diseases work. What is the challenge, ladies and gentlemen? The challenge is that we have a ceiling effect. We are in the good condition, in the perfect condition that we have many drugs, but we have these drugs actually only tackle a certain proportion of the patient, and you can see none of them are actually going to 100%. They tackle more or less 50% of the patient are going to get better. And this is a challenge for the development of new drugs. Because, for instance, one example, this is a cytokine inhibitor against GM-CSF, which is a key molecule to attract neutrophils and macrophages, which is obviously very important in inflammatory diseases. But you can see when this is tested against the TNF blocker, is here the TNF blocker, and this is actually the blocker of anti-GM-CSF, and this is a response in arthritis. You can see that this drug is actually worse than a TNF blocker, or at least not better. So the company basically are discouraged to continue this drug. Although it's actually a very good drug, we would have been perfectly fine if we would have had this drug 20 years ago. So this is a challenge. For new drug development, it needs a better stratification of the disease away from a just phenomenology towards a molecular driven disease phenotyping. So this has been shown before, and it's the same principle. What we usually do nowadays in the clinics, we lump together different patients with a different, basically, clinical presentation, but we don't accept, actually, that these patients are very heterogeneous, and based on the molecular pattern, you have different endotypes of the disease, with probably a very different response to treatment. And actually what we are doing, we don't do precision medicine nowadays. We do imprecision medicine. What you see here are the best sold drug in the United States, and you can see only in the blue figures, actually the drug worked. And in all of the red, the drug did not work, which is sometimes going to 1 out of 20 in this field of inflammatory medicine is still 1 out of 4, which is actually not very good. And why is that? I think the main reason is that the condition and the diseases today are defined on clinical symptoms rather than underlying molecular and cellular events. So how to approach that? I think what we lack is a better analysis of the tissue, of inflammatory tissue. And there are several approaches now underway to make this situation better. For instance, this is a strap study which is done in the UK, where patients are actually phenotyped based on the molecular pathology in the joints, and then are subjected to different kind of treatments. And you can see that first results of this approach are actually quite encouraging. You can basically subdice, you find endotypes of the disease: lymphoid-driven rheumatoid arthritis, myeloid-driven rheumatoid arthritis, fibroid rheumatoid arthritis, and you can see response to therapy, to classical therapies, actually, especially in this subset, lymphoid-driven disease, while in this subset is actually not that good. And that allows actually further room for better drug development and further improvement of disease classification. Well, I want to share with you 3 examples where actually where are the frontiers of the field. One frontier of the field is understanding master players of the reprogramming of cells. Because in an inflammatory tissue, over the time, cells reprogram. They change their phenotype completely. And to understand these master switches is extremely important. Why? Because this is actually an inflammatory feature of a disease, and this is a chronic feature. And what you see, this is in the lung, in the liver, in the kidney, in different organs. And you can see here fibroblasts, resident cells. So here they are inflammatory, but here they start to make tissue damage, scarring of tissue, which is very bad because you cannot overcome this, and you get a damage in the involved organ. And you can see here one of the master control factors is PU1, which is a transcription factor, controlling actually this reprogramming of the fibroblast in different chronic inflammatory tissues. And this is basically based on the effect of TGF-beta, chronic TGF-beta stimulation, which then induces PU1 and starts actually the reprogramming of these fibroblasts, starting to produce extracellular matrix, which is required for the scarring of the tissue and which starts actually the organ dysfunction. Second example is actually that we still don't understand the tissue, how the tissue works and the tissue is composed. This is an example how you can overcome this with modern imaging. This is light sheet microscopy of a joint and with reporter mice, and you can see this red membrane here, which is actually the synovial membrane. And people never understood what is the surface actually of the synovial membrane. These are macrophages. These are resident macrophages actually, which are there to clean the joint. Because we could not walk away from a mammoth in the Stone Age if our joints would be full of cells, if we would have been arthritis. So it's an immune-privileged site, the joint, which is related to macrophage function. And we better understand with single mRNA sequencing now that different macrophage populations are in the joint, and these macrophage populations are not only bad, they can actually also basically overcome inflammation, and especially these resident macrophages, which you see here as lining macrophage, when you deplete them, you have even more arthritis. So to understand, to basically map the tissue for cells and for cell phenotypes and for cell expression will allow us to much better understand the diseases. And the third example is that we still have no cure of the disease. It's like in HIV. What we do is good suppression of the disease. We make an active disease to a smoldering disease. When we stop therapy, autoimmunity actually triggers the relapse. And this is actually a big challenge, but because at the moment we have very few tools to overcome autoimmunity, which is actually driving always the disease. And there are now different approaches going on to induce tolerance by combined B and T cell inhibition in these kind of diseases. So to sum up these frontiers, first, where we are at the moment, I think we understand there are distinct cytokine profiles in individual immune-mediated inflammatory diseases across the organs. So actually the organs move closer nowadays. There is a molecular rather than a clinical disease classification necessary in the future. And this will allow actually to create more mechanistically based treatment approaches, more precision medicine type approaches. And finally, what we need is actually a molecular and functional characterizations of the cells in the inflammatory tissues. And that reflects very nicely what we have heard in Alzheimer's disease and in other kind of conditions. Thank you for your attention.
Thank you very much. It's a wonderful overview. Yes, please, go ahead.
Thank you for a wonderful presentation, which I think is very relevant for many other areas, and I think extensive cross-collaboration will be necessary to tackle these challenges. I have a question about inflammatory memory. You talked about switches. Do we know anything about epigenetic mechanisms when, let's say, a tissue that is inflamed is not the same before and so forth?
Yeah, you raise a very important point. So there is always the question why there is so much chronicity. And one is obviously autoimmunity, but that's not the only reason, because you don't have always antibody in diseases. So one is epigenetic reprogramming, and actually PU1 is typically epigenetically reprogrammed. So basically allowing a phenotype, a stable phenotype, which is associated with chronic inflammation. But also there are other immune-driven memory, there is immune training. Leo and Mihai are doing that very much, or also memory T cells, which are then in the tissue, even in the tissue of diseases which is in remission. They stay there, they are long-lived, and then can re-trigger disease at the same spot where it has been before. So these are the key points. We have to better understand the cellular composition, molecular composition of the tissue, also in remission stages, to judge why there is actually this high rate of relapse when you stop the treatment.
Great points, thank you.
Super nice talk. Can I first say this session is mind-blowing. Like really, this is what LifeTime is all about, and I really thank all speakers for this. So we've had discussions on organoids versus mouse models versus better clinical data and so on. So you just showed joint inflammation. So I guess you have the people when they already have joint inflammation in the clinic, right? So what is your view on how we can feed better data to the bioinformaticians and so on this particular disease? So how do we do this in vitro with an organoid? Do we do, like Bartosz Stroper's point about human cells into mouse models was also very, very nice. So what is your view on this?
Yeah, I think organoids and all kind of in vitro experiment help. Yeah, but at the end, what you need is also an in vivo basically tissue collection and to basically characterize the actual state in vivo in the tissue. And this is more and more possible because many of the organs are actually easy biopsiable, like the skin and the gut, but also the joints are now easily accessible. Organoids can help us if we have a certain when we know the cell and we suspect the mechanism. For instance, typically an example of organoid implementation in inflammatory medicine is gut organoids, where you basically can test how certain mechanisms works on epithelial homeostasis, which is very nice. So that gives you a mechanistic view, which is sometimes hard to get in vivo in the human situation. So I think it's always a puzzle. You need an in vivo actually biopsy, and you need actually then also an in vitro validation, so to better understand the diseases. Yeah? So it's not only one technique which is actually solving everything. So you need always the combination of several, and ideally you have similar results. That's then the best validation.
Yeah, fantastic talk, Jörg. Just to make things even more complicated, I fully agree with you that we need pathophysiology and mechanistic definition of disease. On the other hand, just to should we not put together actually the old knowledge and the new knowledge, because maybe IL-17 or TNF, to give some examples, might work different in different organs. So in fact, we would need, let's say, to take care of both the microenvironment of a certain organ and the pathophysiology of that immune mechanistic disease. So to
Mihai, I fully agree, and a very nice example is, for instance, that people always thought that IL-23 and IL-17 are the same. Yeah? But the production is very tissue dependent. Yeah? So 17 production can be 23 driven when there are a lot of dendritic cells around, but it can be completely independent of 23 when there are no dendritic cells around. So the resident tissue composition is extremely important, how cytokines are produced, and probably are also relevant then for different organ responses in inflammatory disease. You're absolutely right.
All right, last one.
Yeah. Thank you very much. It was really beautiful. So I was just wondering whether you're thinking about looking at endogenous retroviruses in the inflamed tissue, how retrotransposon are regulated. Are they still, under repression, or they are active there? Because they can be also a source of inflammation.
Yeah, you're right. I'm definitely not an expert on retrotransposons, and I know a little bit of the literature. Some of the arthritis work is suggested that actually this synovial hypertrophy, this proliferation of resident tissue, which is in adjunction to inflammation, is retrotransposon L1 driven, for instance. So there are some concepts here, but their elaboration is, I would say, limited so far. So there's still enormous room for better understanding there. So there's limited data on them. I believe they play a role, but I'm not the super expert on them, I have to say.
Okay, thank you very much. Wonderful. And we have to continue with the program. Thanks again. Another applause. And I ask Wilko Weichert to come to the podium. Wilko is a pathologist, originally trained in Berlin, several years in Heidelberg, and since 2015 head of pathology at the TMU in Munich. And he's known for his molecular pathology of solid tumors and work on biomarkers. And we ask you to present your view on cancer in this context.
Peter, thanks for the kind introduction, and thanks for the opportunity to present on cancer today, which is very close to my heart since, as you heard, I'm a clinical pathologist already doing morphomolecular patient stratification on an everyday basis. And as a translational oncology researcher, we are trying since decades to bring the stuff you heard yesterday closer to the clinic and to implement something of the things which you've already heard about. I have to make two disclaimers in advance. This will be a decidedly clinical talk, so I will come from the clinical viewpoint here. And I will exclusively represent my view, because there are many issues where you can have different views on. When it comes to cancer, let's start with cancer. The question, why should LifeTime tackle cancer? I think this hasn't to be answered by me. You've heard the talk yesterday by Angelika Eggert with a myriad of examples already where single cell analysis changed the course of cancer research already. And if you have heard the talks yesterday, you might have noticed that almost all of them had a minor or even major part on cancer in it. So I believe that cancer is kind of a poster child when it comes to the application of the triplicate of methods which we focus on in LifeTime. But let's add some numbers here. If you're just looking at sheer numbers, and these are mortality rates from Great Britain from the year 2011, you see that out of 500,000 deaths there, approximately 150,000, the green ones over there, are cancer-related, which makes cancer the major killer in developed countries already. Cancer has surpassed cardiovascular diseases, which have been in the lead for decades. And with respect to this, and this is one of the reasons, the other reason is the overt cruelty with which cancer kills patients, why this disease has been nicknamed in this very readable and recommendable book on the history of cancer research and the emperor of all maladies. Well, some more numbers. If you look at mortality rates over the years, over the last decades, you can see that when coming to cancer, we were not that successful by the research we did and the implementation work we did, specifically again compared with the people working in cardiovascular diseases, where you see steep declines. And this is also represented here, specifically in medium income countries. You see only a little bit of a decline in mortality rates in cancer. However, we have prevented some cancers due to research in novel therapies. This is here represented by the orange areas. You see that the incline of mortality rates is kind of flattening out. So obviously we have some success, but this is not an unambiguous success story. And this is obviously one more reason why cancer must be tackled and must be tackled with full force in the years to come. So the current situation is not yet satisfactory, but I believe that most of the people who are here in the audience working in cancer do also believe that we kind of have a unique opportunity right now to do something like this. And how should we do this? And I will not comment on this at a very length, since this has been discussed yesterday at length. There is obviously the possibility right now to do molecular profiling on an unprecedented level. There is the possibility to take all this multi-omics data, integrate it with computational methods, and learn something out of this when it comes to patient stratification. And for cancer, there's another aspect when it comes to computation, which is kind of interesting in my view, and this is integrating multi-omics data together with morphology data, and not only tissue morphology, which means histomorphology, but also imaging data, which is delivered at great speed and at great depth in cancer characterization in living patients already. And certainly we have the possibility to use model systems, which also have been extensively presented yesterday. So let's have a look at how you can apply this triage of methodology in cancer. And the first place where you can apply this is certainly in prevention and early detection. And Nick also referred to this yesterday in its introductory talk. And it's probably really important in cancer to early detect this disease, because early cancers can be cured by something like surgery. Late cancers in the metastasized stage are usually deadly and cannot be cured at all. Then we have this big field of improved patient selection, probably the most rewarding one and the lowest hanging fruit when it comes to cancer research and implementation of LifeTime technologies, throwing whatever molecular method on the patient and then saying, okay, the patient should receive fancy drug A or fancy drug B. And then we certainly have the field of novel treatment strategies, which have to be developed in novel drugs, which is only possible in close cooperation with pharmaceutical companies here. And what I'm going to do in the next 7 or 8 minutes is I'm trying to give you some examples. And these are examples where LifeTime technologies can be used today in clinical practice. So this is not something where we have to think about how to implement something in 5 years or in 10 years. It is about how you can use and combine these technologies and use them today in an experimental clinical scenario. Let's begin with early detection. As you might know, there are large screening efforts nowadays producing millions of imaging data sets, for example, with mammography screening in breast cancer, with low-dose CT screening for high-risk patients in lung cancer, and all these pictures have to be viewed by a skilled clinician, which is usually a radiologist, which is not good because radiologists are expensive, they are rare, and they may fail because they are human. So this is clearly an area, and there is some very, very exciting data out there where computer-aided methods combined with AI might help clinicians to actually find those patients, those needles in the haystack, which mean that the patient has a small nodule but is developing cancer. And this can be done with very nice sensitivity rates, kind of dependent on the size of the lesion, obviously. And combine something like this, and this is very early days now, combine something like this with single-cell analysis out of blood or cell-free DNA analysis out of blood, and you've heard about this yesterday, might increase sensitivity rates to really, really interesting figures here, certainly still clinical stage depending, but combining these two methodologies will really have an impact in early detection if you design a nice clinical trial to do something like this. Let's move on to the next point, which is patient selection, which is probably the most important point here. The first one being selection by applying any type of omics technologies, in our case, obviously single-cell omics technologies, how you can use models in, for example, co-treatment clinical scenarios in cancer, and this is very much important, how to translate all this. It is really fancy to learn things in biology. However, if you ultimately want to help the patient, you have to think about how to implement the technologies you're developing early on into something which is at least experimental patient care. If you don't do this, you will not have any impact on clinical care in the end. So why select patients anyway? We already know that this works. We know this from prototypical entities like lung cancer, where we already do multi-gene sequencing on a routine diagnostic manner for all our patients, and then define whether a molecular alteration A, B, C is present, and actually stratify the patient and give them the corresponding drug. We have an increasing portfolio of approved targeted therapies which we can use, and we have the phenomenon that by stratifying all these cases on a routine diagnostic basis, we already know that there are pan-cancer alterations like, and this is just the last but very exciting example of an alteration, translocation of the NTRK gene, which can be found cross-entity in a minority fraction of patients, so a very minuscule minority fractions of patients. However, if you have such a translocation and you receive the matching drug, which in this case is larotrectinib, you have a tremendous response there. And this is something which you can't see, which you can't detect by imaging. This is molecular typing. If you want to implement something like molecular stratification approaches into large-scale clinical scenarios, what you need is obviously consortia. And these consortia have to fulfill two criteria. The first criteria is they have to be interdisciplinary. You need clinicians, you need translational oncologists, you need pathologists, you need bioinformaticians, you need basic science people working together on this. The second prerequisite, which is quite important, you can't do this single center, or usually you can't do this single center. So you really have to try to build larger consortia working in a nationwide manner or even in a European-wide manner together to recruit the patients you are actually interested in. I'm going to give you an example, and this is just a prototypical example how large-scale molecular analysis can be implemented into patient care. This is an initiative we started in 2016 in the framework of the German Cancer Consortium. What we did, we set up a trial setting where we included patients, last-line patients of different tumor entities. We stratified them. They all received a whole exome, a transcriptome, an epigenome by 850K profiling. We then did bioinformatics on all this data. We validated the lesions which are potentially druggable in these patients, and we actually treated the patients afterwards. And I'm going to show you some data of 1,500 patients here, where we had treatment recommendations in 80% of patients and received disease control rates in approximately 40% of the patients who were treated. And that this makes a difference, you can see here the progression-free survival curve under the last systemic therapy the patients received, and as you can see here, under the following molecular therapy. And please remember, these are last-line patients, so they have no hope whatsoever for any treatment which makes sense anymore. And if you treat these more or less hopeless patients with molecularly targeted drug, you kind of improve patient survival. However, as you can clearly see, this is not an optimal curve. An optimal curve would be here. So there is some room for improvement here, definitely, where I hope that probably novel technologies and novel combination of the technologies will come into play. Another very important fact, and this is really important, if you do something like experimental patient care, the good thing is not that you're helping an individual patient that might or might not work, and it doesn't work so well as you've seen. The good thing is that you are producing these data sets, which are combinations of clinical data, response data, drug data, and actual outcome data together with the molecular data sets. What you then can go do, if you have a sufficient number of patients, you can go back and data mine this for the real interesting things. And this is just one example how to do this. This is just an example out of a myriad of examples, not only from our program, but from several other, hundreds of other programs as well. We, for example, selected those young patients with pancreatic cancers from our cohort. We then noticed that most of them carry RAS mutations. Okay, not that interesting because undruggable and you can't do anything against it. But then we had a look at the other patients and we noticed that they had recurrent NRG1 fusions, or some of them had recurrent NRG1 fusions, and NRG1 fusions do activate EGFR signaling, so this is druggable. The patients received afatinib or alertinib pertuzumab, and as you can see here, progressive patients before treatment and then stable disease or regressive disease after treatment. And these results of a serial individual treatment effort which we made on the basis of our molecular data led to a prospective clinical trial right now and will probably, if this comes true in a larger number of patients, be a novel treatment modality for those patients with this molecular makeup. This is just genomics. There are huge efforts in epigenetics. You probably know this from neuro-oncology. The entity typing is done by epigenetic means. We have large consortia working on including imaging mass spectrometry into profiling of patients specifically to define entities. There are some approaches on adding quantitative proteomics here. We just talked about this in the last talk. And it would be certainly by no means complicated to set something like this up for a single cell approaches if we really want to and if we are dedicated enough to do something like this together. This is just the example of proteomics I was talking about. You've heard yesterday by Angelika Eggert about the INFORM trial, which is even a pan-European trial on childhoods with cancer. And I told you about the master trial. We took all the sarcoma patients out of these two trials, and all these sarcoma patients will now receive a full proteome and a full phosphoproteome, and we will add this information to the genomics information to see whether we can learn something additionally there. So much about patient stratification. So implementing something like this is possible. Another very fancy thing to do would be to use model systems which have been presented yesterday and put something like this into a co-clinical scenario. So what we can do and what is being done, however, there are certain technical hurdles which have to be overcome. You can take organoids and you certainly have to automate this process since there are time restraints, obviously. But if you overcome these hurdles, you can take these organoids, you can drug screen them, and then define which patient receive which drug. And this, on a very, very early basis, has already been done. You can, and this is just a pan-cancer experiment here, where they have made organoids, they screened them, and they actually administered, depending on a Z-score, the respective drugs to the patient, and all the ones in light brown here are responders. So you can see, taking a robust organoid model into a co-treatment scenario in cancer would absolutely be feasible, just in parallel probably to multi-omics stratification. That would be really interesting data sets to produce. Well, you've heard a lot about how models can be used in cancer for modeling diseases. Jürgen Knoblich already presented this here, his mini brains with the specific molecular genotypes, which then means you can use these models to actually define which treatment works best with which genotype, and then select patients based on these genotypes for the specific treatments. That is really a fancy tool to apply in cancer. You can even combine this. This is an example from Dieter Sauer's lab together with us, where we take adenomas out of patients, so colorectal adenomas out of a patient. We CRISPR-Cas them with specific alterations and bring them back into the gut of mice by endoscopy means, and then treat those mice to see which phenotypes respond. So there are infinite possibilities in cancer to combine these modeling systems together with innovative ideas how to learn something about the treatment of actual patients in the end. And so this is my last slide. What we have to do, in my view, in LifeTime is we have to develop the technologies, which will happen anyway if you look at the researchers which are participating here. a harder task would be to integrate this, so to combine computational modeling with multi-omics strategies together with innovative models. And the hardest task, but this is something you have to do early on, and this is something where you definitely have to include clinicians and clinician scientists to bring this into the clinic, is to implement the things you are doing in an experimental clinical scenario. So I believe that such a consortium offers great hope in this regard. We just have to build the strategies early on to kind of have an outcome in the end. With this, I'd like to conclude. Thanks for your attention. If you have any questions, I'll be happy to answer them.
Thank you very much. Comments? Cancer is so obvious. So the question was about microbiome, for those who didn't hear it.
Well, the question was whether microbiome might have any impact in cancer stratification treatment whatsoever. The definite answer is yes. The data is already out there in the immune oncology context. It has been shown that the specific composition of the gut microbiome is actually a very good predictor for immunotherapy responses. However, the crucial question will be, and there are two crucial questions there, the crucial question will be, could we make a biomarker out of it? So is it possible to diagnose something like this? I believe yes, it is doable, it's just a matter of technology. And the second question is whether when we modulate that, do we see any augmentation of responses in the combination with immunotherapy approaches? And there's already early data that this is the case. So I believe this is one of the very exciting areas when it comes to implementing and combining technologies.
All right. Yeah, last question. We have to hurry up a bit.
Yeah, so that's a quick question. So thanks for a great presentation. So one impression I have is that the type of data that is being generated by LifeTime very elegantly works with, for instance, developmental problems and so on. But with the type of treatment ambition that you have in cancer, having actual pharmacological data and information about how drugs interact with the state of cells seems very important. And that's not necessarily a data type that is being generated very much by drug companies at the moment. So do you feel that pharmacological knowledge is really compatible with single-cell data at this point? Or how would you view that?
Well, I believe that both modalities must be combined to actually
Yeah.
learn how they interact,
Yeah.
and then to exploit this knowledge to stratify patient treatment. I think we have to include this part into something like the LifeTime Consortium if we want to make impact in the end.
Okay, Nicholas?
We typically think about dissociated tissues and so on, but I think the reality in a few years it will be that at least in 2 dimensions there will be just a spatial profiling done in one way or the other, and probably in 10 years 3 dimensions will be standard. I think it's very clear that it will go this way, and I think we should strategically also think in this way. So maybe you can comment on this from the cancer perspective.
Yeah, well, absolutely. And there's some very recent, brilliant data out there that something like transcriptomics can be done on slide to have a spatial resolution there. And for pathologists, this is kind of a dream, what you can see there, because it's visualized molecular pathology, so to say. And exploiting something like this, clinic-wise, would be perfect. It's just make these technologies simple, transfer them to a larger patient population, and then see what we learn.
Okay, thank you very much. I think we have to continue. We have 3 more short presentations selected from the abstracts. The first one is Céline Vallot from Institut Curie, and she will present her work on chromatin, single-cell chromatin profiling in breast cancer. Please.
Hello. So what I want to do today is give you an example. Sorry, let's have some water first. To give you an example of a technology development, a quite recent one, that seems quite promising in terms of translational perspective and could be of interest to some of you. So to set the stage a bit, my lab is interested in molecular processes of tumor evolution. So very general things, it has been clearly shown now for, quite some time, that in terms of molecular evolution processes, there is also a contribution of both genetic and non-genetic processes. And what's really interesting, and is a lot of interest to us, is that you can see at the same time selection of rare pre-existing features, as well as acquisition of novel molecular traits. And this is really important if you think about the translational perspective of this, because it's not the same to treat things that already exist and target them, and to target things that are acquired along the way during treatment, for example. So what I'm showing here is actually two of my favorite latest examples of really how a single cell has been able to shed light on mechanism of tumor evolution processes, and really in the context of cancer therapy and resistance to chemotherapy. And so, of course, it has been now clear that single-cell techniques are revolutionizing the way we think and we appreciate tumor evolution processes. And here's the example of DNA and RNA sequencing telling us, again, that there's both genetic and non-genetic features that are going to be already there, but also acquired for during the treatment, and here chemotherapy. In this case, again, it's most on the microscopy side, but this paper is telling us that there are transcriptomic features that are already there in the cell population, but you need to acquire additional features in these cancer cells to become fully resistant. So here it's example of DNA and transcriptome, and I'm here to talk about chromatin. And this is really the early days of single-cell epigenomics. Most of you already know that. So what we're trying to do in the lab is really to tackle the concept of chromatin plasticity. And if I may just bring about this concept, it's clearly shown now in cancer that we have an abnormal really distribution of chromatin state. And the field is really getting now at the moment where it's trying to understand why and how this is happening, what is giving to the cancer cell. And what we think, and many lab thinks, is that those chromatin landscapes are really setting the stage for what transcriptome can do and cannot do. If you think about repressive chromatin states like H3K27 through methyl-mark that are here to repress transcription, well, it's believed that displacing it around is going to tell you either if you repress abnormally chromatin state, you're going to really prevent transcription from happening. But in cancer cell, if you lose it, you might be giving the potentiality to the cancer cell to have transcription happening at these loci where you're losing this mark. So what I'm telling you is that having this chromatin landscape information is completely complementary to knowing what's happening at the transcription level. It's not equivalent. Chromatin is a potential, and the transcriptome is telling you what's really happening. So when you talk to MDs, I'm really trying to tell them that we need this chromatin information to have a complementary view of what's happening in terms of molecular processes. And so our aim here is to understand, in my lab, the heterogeneity of this chromatin feature and really have the notion of dynamics in time in tumor evolution processes. So this is real nice, but when I started, we needed technologies to do that. So that's where we teamed up. Sorry. Yeah. I don't know, the videos, yeah, it's going to work, maybe. So that's where we teamed up with physicists, microfluidics expert, and we set up really a workflow to study chromatin marks, so chip, at the single cell level. And just to cut a long story short, this is really, if you compare it to single cell transcriptomic, for example, where you have one step of microfluidics, here you have three. So it's really thanks to the expertise of microfluidics that we manage to really have chromatin prepared from single cells. And these chromatin fragments have a barcode like we see in every traditional single cell experiment. And so when you perform your IP, you can guess and you can really read in the data which chromatin fragment is coming from which cell and etc. So with this type of pipeline, we're now able at Institut Curie and in other places at the SPCI, able to perform single cell chromatin profiling of many different marks on 3,000 cells and really have an idea of how these marks are distributed in terms of in complex samples as tumors. So this is just to tell you for those aficionados of single cell, this is how the data looks like. You have about 10,000 loci that you can really immunoprecipitate per cell, so it gives you quite a thorough epigenomic map of each cell. And this is the reality, okay? Everybody tell me, what is the data? Each line here is a cell. And what you see is that the data is quite sparse, okay? But it's really getting there. We're getting to the point where we can see, for single cell, like H3K27 three-dimensional distribution in this case. And what's really nice with this kind of data is that we're working on the droplet system. We don't have those many batch effects as we do see on the 10x kind of platforms. So what did we do with it? The first thing we did was to profile a PDX, or patient-derived xenograph system. So we were fortunate enough that a patient from Institut Curie gave her luminal tumor for research. And so we had one part of this tumor that stays sensitive to tamoxifen and the other that became resistant after several rounds of tamoxifen treatment. In this case of resistance, or acquired resistance, we didn't see any copy number alteration or major driver of resistance that were mutated. And what we did see, we profiled, so we really led, without any a priori, a data-driven approach. And when we profiled at the single-cell level chromatin of these different tumors, what we saw here, so let me walk you through it here, it's all the cells versus all the cells, and the color is telling you how much the chromatin landscape, H3K27, is correlated between one cell and the other, genome-wide. And what you directly see is that if you mix the cells from the two models together, you see that there are two main epigenomic profiles. That's easy to see. But then what you also directly see is that some cells that do come from the sensitive tumors are highly resembling, have the same epigenomic landscape as the one coming from the resistant tumor. And these cells make about around 16% of the cells. If you challenge the data, you remove some cells, remove some loci, it doesn't move a notch. There are still 16% of the cells from the sensitive tumor that look like the resistant cells. So we were quite surprised to see this was invisible at the bulk level. We couldn't detect this population. So just to tell you that the data now is good enough to perform, so as you've seen, clustering and without any a priori, but also to perform differential analysis at the single cell level. We can pinpoint the loci that are really characteristic of these different epigenomic layouts. And what we saw actually is that a lot of things are moving around. Mostly we're seeing demethylation in the resistant and resistant-like cells, which was kind of expected actually. And it's happening at loci that do make sense, so you maybe cannot read here, but it's happening at loci that are involved in mammary cell identity. So what we're thinking here is that perhaps we're seeing demethylation at genes that are involved in changing the identity of the cells from luminal to basal, for example. So it's really, we're really now studying this differential enrichment loci. So just to finish on that, you can tell me, well, what would you have learned doing the standard 10x transcriptomic analysis? And this is where it got interesting. More interesting, I would say. But what we did actually was on the same pair of tumors. Forget about what I said on the epigenome. We studied also with a standard single-cell RNA-seq approach to say, well, what can we learn at the transcriptomic level of this pair? And actually what we learned is that there's a huge heterogeneity in either the starting tumor as well as the resistant one. And what we learned is that one of the clusters here, the red cells, well, they already activate a lot of the pathways that are activated in the resistant tumors. And you find the same kind of guys that we saw before, the ones involved in basal, breast cancer genes, but we also found some additional pathways, saying that, again, and this is 17%, at the transcriptomic level, there's also a group of cells that do show non-genetic features of resistant tumors. And it's more features than what we saw at H3K27, but it kind of makes sense because H3K27 is not responsible for the entire life of regulation of the cell, right? So it was completely independent. So just to tell you, so we're actively pursuing that, going for tumor samples and so on. But I think it's really important to really see that a strong technological effort that was really a collaborative achievement between 3 labs was really key to having this high-tech and a good data quality for this single-cell chromatin profiling. And that's now really enabling a lot of data analysis. We found, so by different means, that there was this subpopulation of cells with non-genetic features that were already present. So really, again, tackling what we thought about epigenetic plasticity, well, maybe not. Maybe some epigenetic features are selected for just as mutations. So this is clearly something we're studying right now. And just, I want to finish on this very simple scheme, just trying to say that this is all the changes that we're going to see between 2 states and 2 like resistant and sensitive one. What we're tackling with single-cell RNA-seq might be really the top of the iceberg. The things are already highly expressed and moving around. But what I'm saying is that we need other methods, like the single-cell chip, for example, is maybe tackling things that are independent of any expression level, for sure, but they're only a part of what we're seeing in terms of expression differences. Just to say that we need those orthogonal methods, seeing RNA-seq is not all, seeing RTAC-seq is not all. We need to really tackle these kind of molecular evolution processes by different means, and data integration here is going to be instrumental in the sense that we're not seeing the same things with those different data. So how do you integrate when you don't interrogate exactly the same space? I think it's an important question. And for sure, what we're doing right now is moving to patient samples on this. So I'll thank you for your attention, and I'll take any questions.
Thank you very much for a beautiful presentation. Yes, we have time for one or maximum two quick questions. Yes.
So, thanks. Do you think that the chromatin-based identities are stable over time or plastic?
So, well, I think it depends on the mark first to start with. In case of H3K27, that's why we chose it, because it's kind of stably transmitted through the generation, but it's still plastic because we know in development that it needs to change around, right, to really define the cell identity. So what we're doing right now is to combine this to lineage tracing approach, for sure, to test really if it's the same cells that are sharing their pattern, or there's a kind of stochasticity that's being selected for. So that's what I cannot really answer right now. Yeah.
One very small question. So the problem with epigenetics is, we are doing it also, is that you have many marks. So what do you choose from, and how many do you need to assess to get actually the true capacity of the cells to react?
So yeah, so I think it's a very important question. For TAC-seq, for example, because people always ask the question, it's 1% of the genome that's interrogated. These open regions make for 1%. Here we have tried to take the approach to look at repressive mark. We make about 10% of the genome, but we need to reach 100%, right? So I think it was detailed in the ENCODE project. I need 5 marks to make 100%, so let's achieve 5 marks. It would be already a good thing, right?
Okay, thank you very much. Unfortunately, we don't have time to go further.
So I'm going to talk today about our multi-omics approach to profile cardiac progenitor functionality using our unique model system of cardiac spheres, or microtissue, as I will call them. So as we heard already quite often during this symposium, we differentiate pluripotent stem cells using a developmentally matched protocol into different lineages. Recently, we have developed also a new protocol to combine these lineages into a 3D microtissue or a sphere. These microtissue encounter different morphological changes as compared to the single cell culture. And we think that these morphological changes and also cell specifications are mainly driven by proteome changes. However, we're missing a proteome approach to characterize these changes on a single microtissue level or single cell level even. So our lineages have been profiled quite extensively using transcriptomics approaches. However, as you can appreciate from this image, there are some cells where mRNA levels and protein levels do correlate. But in some other cells, they might even anti-correlate, and we can only determine these changes if we do a complementary approach where we look at mRNA levels and also at protein levels. So we know by now that RNA is an unreliable proxy for protein expression, and therefore we also believe unreliable to determine cell specification and morphological changes in these tissues. So since I'm very much interested into these morphological changes and very early cell specification, which are mainly driven by protein expression level changes, extracellular matrix components, and also signaling pathways, which cannot be determined by current transcriptomics analyses, I aim to develop a proteome global approach to determine these in my model system. So we aim to determine and integrate our proteome levels with the RNA that we have already determined in these microtissues. The main challenges that we're aiming to overcome with our technique is nicely illustrated in this mouse embryo whole mite in situ hybridization analysis. Since I told you that I'm interested into early development of the human heart, we of course deal with very low input material. You can see here from 5.5 to 7.5, we're additionally dealing with quite rapid expression changes and therefore quite high interdonor variability. This prohibits us to pool our samples and do bulk analyses, since that might mimic the main expression changes that we're interested in. And also, since we're dealing in, for example, in the mouse development with high in vivo complexity, we started to aim for a different approach. In the lab, we developed a protocol that is developmentally matched in order to differentiate human pluripotent stem cells into several lineages. I'm going to focus today on the myocardium and the endothelium, since we have developed, so you can see on this nice illustration, that we have been able to differentiate them in these two lineages. And further on, Pablo, a PhD student in the lab, developed a 3D protocol to co-culture them to drive maturation of these very immature cell types and hopefully mimic human heart development in a more improved way. So what you can also see on this nice video, I hope that works. No. Okay, it doesn't play. However, what you could see, now you can see, our cardiomyocytes are functional in 2D and 3D, as you can appreciate from the videos nicely generated by Pablo. And what I am personally very much interested in is the difference on a transcript and proteome level between these 2D or 3D differentiated cardiomyocytes. As you can appreciate from the videos, they do look quite different and they also beat quite different. So we assume that there is quite some changes in transcript and proteome level between the two species of cell types. So what we have been doing so far is profile single microtissues and 2D differentiated cells on a proteomic scale and a transcript scale. On the left-hand side, you can see that the 2D differentiated cells and the 2D pluripotent cells cluster nicely apart from our 3D spheres. We can still see quite some spread between the samples, however, we are still working on improving that. On the right-hand side, you can appreciate a quite similar picture looking on the transcript, 500 most differentiated genes, where you can again see pluripotent and differentiated 2D cardiomyocytes cluster quite far apart from the 3D spheres. So this gives us an illustration that if we have a look on proteome and RNA on a global scale, we can see quite some same trends. However, if we go in more detail and look at the pathway analyses of protein and transcript, we can nicely appreciate it as we expected if we compare 2D to 3D cardiomyocytes, that Wnt signaling changes a lot. And as you can also maybe already assume, cytoskeletal regulation is quite prominent in our data set. However, we also know that cytoskeletal regulation is mostly executed by structural proteins. So if we integrate shared pathways, meaning we looked at the overlap of protein and genome data, on the x-axis you see the protein count and on the y-axis you see the gene count, we can nicely see that something that is very prominent in our proteome data set is almost not visible in our transcript data set. So we can see that with only looking at mRNA, we would have overlooked these prominent cytoskeletal changes in our system. Again, if we look at the transcript data, we can still appreciate that with just looking at the protein pathways, we would have overlooked the importance of TGF-beta signaling. So I think this analysis quite nicely illustrates the need for the complementary and integrative analysis of proteome and transcript data. We have partially diverging profiles, but still quite a lot of things in common. With that, I would also already like to go to my future perspectives, where we are trying to integrate transcript and proteome profiles over the whole differentiating process of cardiac development. We would like to establish an extracellular matrix expression profile of our microtissues and further profile the post-transcriptional modifications, which of course cannot be done using transcriptomics approaches. If you would like to have a little bit more information about the project and the ongoing post-translational modification analysis, my poster is P18. And with that, I would like to go already to my acknowledgements and would like to appreciate all of the people that contributed to that project. And since we have been talking a lot about single-cell proteomics, I would like to draw your attention to our upcoming first European single-cell proteomics conference, which is happening in August in Vienna. And also people that we already talked about will give very impressive talks, and you can register still, and we are looking forward to maybe see some of you in Vienna. Thank you.
Thank you very much. A very interesting talk. Do you think that you can integrate at a certain moment also aspects of modification such as glycosylations of proteins and things like that, which are also very important for the function in the end?
Yeah, so of course this would be the ultimate goal, to maybe integrate a transcript with post-translational modification, glycomics, lipidomics, everything would be interested. I think the more we integrate, the more information we gain. It's just a matter of detection limit and of course technological advantages that we're looking forward.
Okay, thank you very much for a fantastic... You have, well, one last question, burning.
Yeah, just a quick one actually. Looking into the proteome, did you see changes in kinases, for instance? Because, you know, many of us think, okay, when you have phosphorylation, you don't really change the concentration, but on the other hand, you also can change protein stability. So do you see much of that or not?
We do see that, and that's why we are also much more interested in post-translational and phosphorylation changes.
Yeah. Thank you very much for... to all the speakers, and thank you for being with us with this very interesting session.
Before you go away to enjoy your lunch, may I please remind you of the breakout sessions that will be starting after lunch. So please remember that for the people who have already signed up for these sessions, the room that you go to is indicated by a colored sticker on your badge. So if you have a yellow sticker, you go to the yellow room. If you have a red sticker, you go to the red room. You also find the number of the table on the sticker. You also find an instruction in the conference bag. There you can read everything. And in case you have not signed up but would really like to contribute, please come to the room of the session that you're interested in. We try to accommodate you. Thank you.
Also, before you go, just to say, yesterday somebody mentioned something about
the wrap-up session. First, I just want to, together with Nicolas, to thank you all for this almost 2 days of work together. Your contribution in many ways is really, really super important for us to define the way for the future and this roadmap that we want to build. And so it is time to hear what could come from this breakout session. And so I'd like to call on the podium the work package leaders from the work package 3, 4, 5, and 6. So, sorry? No, but, well, they have to come in the order, so they can see, they can count, so I hope. So we start with 3. And Giacomo, your turn. So sorry for the confusion.
Yeah, folks, it was a fun exercise for everybody. Okay, we are in the single-cell multiomics for those who got lost, and imaging. And so we gave 3 questions for all the others who haven't looked at the questions. It was, the first one was, what are the 3 biggest challenges we need to break through to enable scalable deployment of single-cell genomics in medicine? Yeah, by the way, the questions were probably not comprehensive, and we realized we should have had some other questions as well, but anyway. So the first thing was that, so the challenges for medicine, one big issue is sampling. So to have high quality samples and also longitudinal types of samples. Also, so you frequently get fixed samples. That's a problem when you want to do single-cell biology. Or fresh frozen samples. That's still a problem. So one would need to have a lot of live frozen tissues to make single cells. And so that was an issue. Another issue would be to develop standardized procedures for material handling, cell handling, but also then downstream, producing the data and also process the data. And actually that came up also later on in a more technology issue. I think that the computational aspect was realized that it's going to be a huge challenge. And one of the suggestions was to maybe try to get inspired by people in large consortia like the Human Cell Atlas, so try to provide centralized resources and analytical pipelines. So devote effort and basically bucks to do that. One other big issue is reproducibility. Despite all the marvels that we have heard in the last couple of days, in the common day practice, single-cell omics is not at the best reproducibility level, and we have to work on it. And another point that was felt to be super important is to be able to share expertise, and in particular for data processing and analysis, so even more than for the technology itself. And so this, I think, comforts a bit what has been put forward, that there's a big effort in LifeTime for training, for teaching, also for distributing the material, for distributing the expertise. And also one more thing that one needs to be is to be aware of heterogeneity in samples, in genetic background of the patients, and so in many sources of heterogeneity. That means if you don't have a large cohort of samples, can perturb the results. One suggestion was to go for programs, try maybe to go for programs of rapid autopsy, because in that case you have access to material in a much easier way, and perhaps there could be a small or a part of the effort that could be done. The second question was more kind of a game question. They had to defend 2 possible statements. One was that we have to start profiling small cohorts, 10-ish, 10 or a few tens of people, but having very deep multi-omics analysis, and use that to select markers, and only after we have very robust markers to go towards larger cohorts. Or the second possibility that they had to defend is, no, you have to go for mid-sized cohorts, several hundreds of patients and controls, because the technique must be scalable, must be robust, so, and we need to have predictive power. That question was very tough, of course, and basically people want to have both. They don't want to decide. So of course, they realize that having small cohorts allow you to really go deep, to have very consolidated markers in terms of the biology that you can do. But on the other hand, there are so many confounding elements that maybe you have some robust molecular determinant, what you believe are a determinant of disease if you have a small cohort, but they are confounded, and so when you go to larger scale, they will not be confirmed. So that was a bit of a tricky issue. One thing that was maybe interesting was that maybe that depends a little bit on us, on how we select the cases, the study cases, because if we go in a disease that is very uncharted, maybe, yes, we have good cohorts and so on, but we have little pre-existing knowledge. There we definitely need to have a small cohort. We cannot go to very large-scale experiments. But perhaps we want to select one of these diseases, nevertheless, because it's very interesting. And then for other cases, if we are able to pull out a disease for which we already have very strong pre-existing markers, then we can go for larger cohorts immediately. So that's maybe something to discuss. It could be an interesting aspect to actually have a hybrid approach for different diseases. The third question was how should microscopy and single-cell genomics be integrated towards clinical application in the next 5 years? It was like, what are you going to do next, essentially? And then they had the options which were use them as separate technologies that generate data and then analyze the data by some, what was it, the computer voodoo? It was yesterday's talk by Angelica. So to basically pull out essential information. Or the other thing was to try to develop immediately in situ technology. So essentially doing in situ as much as possible omics to get the molecular markers that reflect the tissue where they come from. And they were also asked to name applications if possible. Here, I think that was quite interesting. We had a lot of people really express the fact that what they get, it's finished. What they get is tissue samples, and that they need to know when they have the omics. It's not enough just to break them up in cells and get omics. They want to know where it comes from. They are used to have the pathological images that they can interpret, and so they need to know where the species come from what cell they originate. And so, sure, one should do omics, single-cell omics to derive markers, but maybe one approach was to have a dual step. Develop markers based on the omics, but then try to have as much as possible techniques where you can look at tens of markers at the same time, preserving the spatial organization. So that was, I have to wrap up. One thing that maybe we can do is to make order in all of this and provide a document that better reflects the responses.
Thank you very much, Giacomo, for this summary of the outcome on this work package. So now the work package 4 with Fabian Theis. So up to you. Yes.
Yeah, I like that. Can you put up my slides? Thanks so much. So we had this short discussion. First, thanks again for this organization. I really I was confused about this World Cafe to start with, as some others, but it seemed to be working out rather nicely and potentially successfully. So we had a discussion. It was the 4 of us for this first question, which you will hear about in a second. Jean-Philippe, yes?
Fabian, I'm sorry to interrupt. I just want to say we have actually, if I count correctly, only 5 to 6 minutes per work package, because I think based on the feedback, it is super important that we also have an open discussion. And we have only 1 hour for the entire session, so I think we should, if I calculate this properly, stick to this. So now you're cutting
us short, right?
Yes, so I'm very sorry, but I think in view of the open discussion.
Sure, I'll take 2 minutes. 2 minutes, 1 minute per slide, is that okay? So I'll skip this one so you know who discussed. Appreciate it. No,
thank you, Fabian.
Don't worry. So we talked about adaptive experimental design. That was the first question. This is, by the way, what always happens to the computational session. So we spoke about that actually first it's a good idea to agree on a question, the experimentalist as the analyst, do experiment design, and then only do the modeling afterwards. You need benchmark data sets. I think computational implementation, in particular across consortia, might be a big important thing to have reproducibility in whatever experimental design you choose. Check what type of methods are. Don't always reinvent, write a new paper about something that's out there. We realized in, I think, quite a series of discussions that communication is an issue, that actually people have very different languages, and stat language doesn't necessarily translate already in a medical language. And then there's this very free type of modeling on the exploratory range that's maybe not as clear in terms of hypothesis as clinical standards. And I think in particular, if we move from those more well-defined treatment questions to those more exploratory ones, the questions are more complex to phrase, and thereby also the experimental design is not as straightforward. We thought once you have done experimental design, you can inform perturbation experiments, but there's a risk, of course, of bias versus prior information inclusion. And then we had some examples that I will skip. I think adaptive experimental design, so this was the additional thing that was put up there, means that you have a data stream coming in instead of only just a single type of experiment, and you might need to adapt methods to that. But then the hard hammer of a pathologist hit us to say that in clinical reality, of course, things might be different. There might be just a fixed number of patients coming in, these type of things. And to include budget constraints. The second question we had discussed, I think, quite lively in a series of discussion rounds was effective medical machine learning, where we focused on challenges in hospital and their impact. We first talked about, well, we talked about data issues, which was labeling, sharing, quality standards, and so on. Very often realized there's no error bars coming with it, so there's some data uncertainty. What do you do with that? If you don't have it, could you maybe ask for it? And we need benchmark where there's a clear positive, negative result. Once you do prediction, it would be nice to give confidence intervals, be very clear about endpoints, if those actually match up with what the clinical expert wants. How to do explainability networks, to really do something not only for the doctors, but maybe include the patients and what's relevant for them, how to tell them about results of the model. Talk about accreditation, if you want to have a pathology prediction, how can it actually be used in, I don't know, some FDA type of thing, and how to do transfer learning, so it might be good that the model gives the outputs that give clear interpretation. Then again, we spoke about prior information, how to leverage that. The model might have bias. If the training set is biased, very known problem in machine learning, and we should have actionable predictions to feed back to Origin 1. Thanks.
1 minute 30 seconds. So the second question was about issues and challenges on data benchmarking, data integration, and data visualization. So I don't have fancy slides, and it's probably better so. It's going to go faster. So there is a very clear need, apparently, from our discussion, to measure the performance of methods, and for that the available benchmarking data sets are apparently rare or too small, so there is a real need to have proper sized, referenced, standardized data sets that everybody can use to measure and observe the behavior of methods. A related idea is to have also standardized samples or cell lines that can be used across labs to calibrate local methods. In terms of data integration, that was understood very simply as combining several data sets produced by several people, maybe several labs, and there the message was very clear, very simple, no surprise, is that to the data one should associate the proper metadata such that it can be really reusable. This is clearly a lot of effort. It needs standardization of the technical, of the descriptive metadata, and maybe there should be a dedicated working group that also liaises with the human cellular class and similar efforts to do that. One good idea was to also have this being addressed in a very community-oriented way with challenges and hackathons. Now, there was a note of caution that standards are very good, But there are these two phases of research, an exploratory phase where standardization is probably less important, and then a more production level phase where design and standardization has to be phased from the very beginning. Finally, data visualization. There is, of course, this high dimension to low dimension projection that is typical for single cell data, and it has been noticed that for biologists it can be challenging that some of these methods are not deterministic, and so maybe there is a more need than usual to have interactive data presentation or interactive even data presentation that go beyond what we are used by our dear journals and publishers. Now, this is also an area where too much standardization can be actually detrimental, because to present always the data with the t-SNE can become misleading, and some variety, and even being able to switch from one visualization to the other would be useful. But the major challenge, which remains unanswered, is to find really visualization methods that provides biological meaning, and this is very difficult. Finally, just to conclude, I might be a little bit biased on this one, but I think for all these aspects, benchmarking and so on, there was a call to interact with publishers, with journals, to find policies and standardizations and incentives to advance on these points. Many thanks.
Okay, I'm going to try to summarize. The question number 3 we had in our session, which basically dealt with data management and how to share this data across the individuals. I'm not going to take much time. I'm going to try to summarize it to the key points. Everybody say that we have to address very well open access and fair access to the data. So we have to have a very good data management plan in place before we submit the next proposal, which we plan to do. Ethics, also very relevant. A lot of people discussing about ethics and what we can do and what we cannot do with such a data sets. Whether we store or not raw data or parse data or analyze data, which is also a very important point. For that, we need quality controls for all the raw data if we want to get rid of it before and not store it. Define specific benchmarks and standards, and probably LifeTime could have a working group continuously that takes care of a continuous benchmark of all the methods associated to the LifeTime framework. Training was very much important. It was said that many of the groups need training on data standards and data storage. And maybe one of the ideas I thought it was interesting is that LifeTime provides a network of data managers that will be sitting in the laboratories where the data is produced, and will be sure that these people are trained to make all the data accessible and storage in a proper way for larger projects such as LifeTime. As for the logistics, whether all this data should be sitting somewhere in a center in Europe, all centralized and private and kept secure, or the other extreme, the cloud. There were a couple of ideas with a radar system, which I'm not going to describe here, or blockchain, that could help us to have somewhere in between the two extreme scenarios. So overall, they also ask us that we should use existing repositories, that we should not reinvent the wheel. The existing repositories have a lot of policies in place that we should learn from those policies when we prepare our data management, and we will do, of course. And the data contribution by individuals should go to a clear goal. That was an interesting comment that I got from a few people. What is the goal of having this data? And that should be clear when the people are producing this data. So this is for Work Package 4, and I just don't want to finish like this. I want to thank all the 12 people who helped us to make this discussion really happen, all the about 100 people that were in that room, and a special Thomas and Fabienne for making the summaries of question 1 and question 2. Thank you.
Okay, I can use the microphone here. So there were also 3 questions in our session. Unfortunately, Giuseppe and Jürgen had to leave. As I said in my introduction to the work package session yesterday, so one of the distinctive features of LifeTime is mechanism. And so in order to dissect mechanism, we need good models, appropriate models. I'm trying to get my slide back, which allow us to study mechanism and perform perturbation experiments. So I have an issue with my computer with the first part, which concerned organoids. So the idea, so we had 3 questions. One is, what about organoids? Where do we stand? What do we need to improve to get better models? The second question was related, but related in vivo models. So what do we need to improve our current in vivo models? And the third question was more about what models do we need to develop to eventually generate data that are sufficient to trigger the attention from the clinicians and the industry so that we can move on directly to translation. So maybe you start, if you don't mind, with the in vivo models, and I will then...
So I will discuss the question on animal models. I think it was clear from the roundtable and also from the interactions that we should really prioritize going to human data, right? So wherever possible, we should with LifeTime really go to clinical data and so on. Also, the same thing is true for organoids, that they would probably, we would make a bigger difference with LifeTime if we invest in organoids than if we invest in, let's say, mouse genetics. However, to bridge the organoids and the human data coming from the clinic, we really very often need animal models. And so the question is, how can we improve this and what can LifeTime make as biggest difference? We came up with 2 main conclusions. The first one is that these hybrid systems where you would have human cells into a diseased animal model, it would allow you to really look at the responses of the human cells compared to the mouse cells and really look at what is conserved, but also what is not conserved. And in fact, you could take iPSC-derived cells from 5 humans and then look at the genetic impact of the different genetics of those 5 humans and then see how they react. So that's one. So we think LifeTime actually has big potential in bridging very good organoid people with very good disease experts and then try to combine and try to transfer some of the organoids or some of iPSC-derived cells into the disease models in animals. In addition, we think actually what probably would be the biggest effect of LifeTime is if we could really put all of the bioinformatics into that, so that you could completely do multi-omics on an organoid, on a diseased mouse model or zebrafish, and then do the same on your human data, and then integrate all of that to be able to say to the pharmaceutical industry and to biotech companies, like if you're looking at this pathway, this we can mimic in organoids, and it works well, and the best organoid model is this one. But if you want to look at that pathway, it's not working in organoids, but in mouse it's working beautifully and it's conserved. But at the same time say, look, in mouse this doesn't work, or in zebrafish this doesn't work. For that you really need to go to hardcore clinical data or in vitro systems. So that's it. That was the conclusion for the animal.
Okay, and I think I will just, because time is running, and I will move directly to the third question, which I think is an important one, that relates to what do we need to take into account when developing our models or choosing our models when it comes to smoothly move to the clinic. And so the first obvious comment is that the requirements will be different from disease to disease, so it's a disease-specific issue. Of course, some diseases are more appropriate to go directly to the clinic, so like when you have a terminally ill patient, you can move to the clinic faster through the umbrella trials or to some clinics, so investigator-driven trials. So another, of course, aspect is that whatever the model is, it has to recapitulate the cellular heterogeneity that is seen in the patient. Is an obvious one, but it's about single-cell sequencing, single-cell profiling, and of course the models have to recapitulate heterogeneity. And of course, some clinical relevance is important here. Histology of the patient needs to be taken into account. Then also going back to some of the things that were discussed during the meeting, we need to take into account gender, and standardization is important. For clinicians, it's an interesting comment for me. For clinicians, the models need to be of human origin. The trust from the clinicians to other models, like mouse models, is always a little bit insufficient. And so models have to be developed from human cells, and better if, of course, these models are derived from human cells, derived directly from the patients, that we treat it in the concept of personalized medicine. A very important point, I thought, was that what we need to do as early as possible, and this will have to be implemented in LifeTime, is to establish a two-way communication channels very early on with clinicians in the design of our experiment, with EMA, so the authority that actually eventually decides whether or not the data are sufficient to go to the clinic, and of course also with the industry. And so it was proposed that LifeTime think about even investing into having a person that would help facilitate these interactions, like an officer from LifeTime that could be. And of course, when testing drugs, if we want to move to the clinic very quickly, what we need to do is focus on approved drugs as opposed to drugs that are not yet approved, so to facilitate the transfer to the clinic. It's an obvious one, but sometimes we tend to forget this. And the last point I want to make is, thinking about models, it's always difficult to think about models without having a clear disease in mind, and we could not really refrain ourselves to, kind of start thinking about models that fit well the bill when it comes to the lifetime paradigms or early interception. So a few diseases were mentioned, like the polyglutamine diseases, like rhizopathies. So this is, of course, for Launchpad. But one interesting comment was made when thinking about choosing the model is maybe what we need to do, it's food for thought, but we maybe want to not necessarily think about disease per se, but more about molecular or cellular processes. And for example, in cancer, metastasis could be one process we want to study. This is non-genetic reprogramming or plasticity, cellular plasticity, which contribute at least to some extent. And that's maybe something that we could do. Or processes like disease in which protein aggregation, and then we can bundle a group of disease. But that, again, is just something that Launchpad can think about. So I think that's all for us, and thank you for your attention.
All right, could I have the slides? Or? No? If not, we will just, it would be faster with the slides, that's one. No, doesn't seem so. Okay, then I start. We had 3 questions, and the first one was on which criteria for the selection of diseases we should use, and we based this on the discussion we had on the workshop on Sunday. And okay, and here you see basically in blue what has come in addition to this list. So the discussion about high societal impact was actually going on the floor quite good, because it's not only economics, it's also political, it's also unmet clinical needs that need to be taken into account, and this discussion should go on in the working groups, I think. In terms of what disease system has a sufficient heterogeneity on the cellular level to be selected, there was a very strong statement that it needs to be single-cell sequenceable, whatever that means in detail, of course, and it should be applicable to AI. The availability of tissue samples and patient cohorts was underlined again and again in all the working groups and all the tables. The models were also seen not only for the pathophysiology and the possible later interference therapeutically, but in particular also for validation purposes. For the clinical need, clinical feasibility, the unmet clinical need was stressed very often, and 2 more points were added: ethical, educational, and educational considerations, and the gender aspects. About the process now, how to do the selection, obviously this is a tricky issue and there are many opinions and there were quite good contributions on the floor. To make an open call with no focus on a disease and decide then was seen in general very negative, but there were discussions between the two extremes, let's say, selection of diseases within the 5 disease groups that I had mentioned this morning. Or should we instead do cross-disease mechanisms? Fibrosis is one of the examples. I think this would restrict it too much. A compromise between these two might be more feasible. We have to see about. Criteria to be released, of course, after question 1. This is what we had proposed anyhow, to have strong exclusion criteria and limitations on this list as well. To do a workshop, this has been planned already, and rank the diseases accordingly was seen by many. The question was whether one should maybe do funding to each of these 5 disease groups and then have a competition in a call with reviewers within each disease group. This is an open thing. Declaration of conflict, of course, there is always the question about am I still on the wrong slide? Yeah, can you move on the slide? Sorry. Declaration of conflict, because obviously there is, for everyone on the floor, the fear, everyone has his own most favorite disease and should and will fight for it. And therefore the question in how much the decision should be done from outside. I think we are so big with so many experts, we should be able to do it. I think we also have the structure of the SAB and the Industry Innovation Board and take already quite a bit care of that. Maybe this is less important. And if you go please to the next slide. Oh, I do this, yeah, okay, sorry. I'm a bit... Huh? That's too fast? That was the third one. Okay. And then, yeah, there were a few more points. Maybe one was one should look at other strong, big European networks and other funding schemes and maybe not do things which they are doing already, like the Bill Gates Foundation, very strong on infection, but there were different views on this. About the bottom-up approach with patient advocacy, we all know this is something we need to do, but there was also quite some discussion we should even increase on that. Also have citizen scientists and charities involved furthermore. About industry was quite some discussion about, and a good point is there might be different funding schemes how we proceed with LifeTime. IMI might be one. If IMI is a funding scheme, of course, it is by definition heavily governed by industry. So these things might have to be adjusted depending on how we go. And the third question goes by Joachim.
Yeah, very short. Long question, induced a lot of creativity. I go quickly through it. Yeah, so how could technology, clinical... Oh, sorry, yeah. So long question, induced a lot of creativity, but I still keep it short. So basically the idea is what do we do during such a long process if things happen and change, and how do we monitor that? So suggestions were to have several governance levels, parts top down, but for sure also bottom up, and it should be lean. Communication that came up all the time. It can be both ways, active and passive, and in both directions, from the experts to the community and back, basically to monitor this. Develop typical flowcharts for decision making so that people have an idea how this works. And that's transparency, basically, and then information gathering, where just a lot of things, we have that on the list. Big data analytics was one of them. It came also that funding might trigger that to be brought in, because if you do the flexible funding schemes, which we all discussed already, then you might be able to reach new things anyway. Calls on all levels, small, large, high risk, and outreach with diseases to social impact. Very important for all of the groups was that we do molecular mechanism classification and not pathological anymore. So that also means that there might be underlying mechanisms that go across the board of all these things. There were a couple of things mentioned: survival of cells, inflammation, infection, and signaling is up here. So the idea was from all of them, we're not making a new disease classification, but we're looking for molecular mechanisms. And the key technology within centers could be used for basically another level of calls. So if we have centers that are good in certain aspects of LifeTime, then the community could basically ask for calls, and then we could get access to these centers. Yeah. And there were a couple of other things, outreach. We saw that what Peter already said. And we should not forget about the biobank people and cohorts. They might also have new things to come up. Last slide, cross-section formats. So, meetings between people in technology and in clinical development and cross-fertilize. That should come, communication again. And then an interesting one, I thought, because that's milestones using as a tool. So really taking things, I give the negative example, both directions. So if a disease is suddenly being treatable by something and we don't need to be more because suddenly all patients for new things are gone, I have been there actually myself once, then you should be able to basically bring the funds also to something where there is more need. So take milestones as a tool to basically adapt to the identification of new candidate diseases. Very lively discussion. I think everybody who took part was, and as I said, sometimes open and difficult questions give quite some creativity. Thank you very much.
So thank you very much for these very interesting summaries. I think it's now time for the open discussion and exchange. So as, there's the other microphone. So I think that, of course, there may be some reaction on these summaries. So perhaps some of you may want to add some comments. Otherwise, we should move on to the next aspect of the discussion.
I think we can just take any kind of questions, and our colleagues from the work packages should please stick around if possible, so that they can
if you can,
take questions when they come to them.
All right. Please go ahead.
So just maybe 2 or 3 comments. First of all, thanks for letting industry participate, and we certainly would like to follow up with that. I do like the idea, which has come up quite sometimes here, to have a liaison to industry. I think this is quite crucial. Second comment I'd like to make is just a simple observation about the necessity, and you cannot overestimate the importance of creating real good clinical cohorts with very well-defined patient phenotypes, I think. And don't only rely on what is there, and don't only just, adjust to, the samples which are already available, but do create cohorts prospectively and do tailor them to your needs. This is my suggestion, actually. Obviously, there are diseases like Alzheimer's where you can't do that because, you would have to reach out for another 20 or 30 years to wait to disease to happen and become clinically apparent. But in other diseases, you can very well do that and tell the clinicians and tell people, what samples you need and what clinical information should be linked to that to really make it happen. I think this would be something very valuable. And my last comment would be, this is more like a political thing. I think you should also have a strong educational capacity building component in your consortium, and maybe you can get also somewhat more participation from Eastern Europe there, so that you can leverage this on a political level.
Very interesting comments. Thank you very much. We should, of course, take note of all this for the future. Thanks a lot.
Yeah, is it working? Yeah. So one aspect that came, at least in the group I was in, is that together with the data storage should come some computational power, because the data is going to be very big, very difficult to move around. I think to do large-scale studies that integrate a lot of information, if there is no dedicated resource that a European researcher can access, the data is not going to be exploited on a very large scale, except by some very few groups who have access to huge compute power. Also, it would be good for the data itself, for to take really advantage of the data if some dedicated cloud comes with the database where the data is being stored. And I think that will be a very important aspect. And it will be also an opportunity to move the benefit of the consortia at a research level beyond the consortia itself, because it means that, for example, someone in a very small place, in a very small research center across Europe, can actually make something with the data. And you could imagine a system where instead of giving money, you could allocate some computing resource onto the cluster where the data are being stored. And this would also take care of the way that you can control who has access to the data, and you don't have to move around the data or to give permission to people to put the data on their own cluster. Understood. Where you don't know what they are going to do with it, basically.
Understood. Yeah, thank you very much. Yeah, so I just want to maybe proactively make some comments because there were some questions I received were similar from different people. So one question regarding the disease models. Organoids are super, but we of course also learned and we know that they have limitations. And so part of LifeTime are of course also classic disease models such as mouse. And just to say this, so if you don't work on organoids or you have super strong mouse models, you are within the scope of LifeTime. So maybe important to point out. Also, if you work on fly, I see a famous fly biologist over there. You are also in the scope of LifeTime because we need to also hash out the lifetime of the mechanisms behind LifeTime, and we all know that model systems are for this very powerful. So this is all within the scope. How do you join a LifeTime, or you have a project idea, what happens? So there, of course, it's on the slide, but also what we are doing right now, the task is that in 1 year we deliver about a 1,000 pages roadmap to the European Commission. So this will happen. And there will be, of course, lots of outlined possible projects in there which would demonstrate what LifeTime science could do. So it is now, within this 1 year, the time has come for all of you to discuss, make proposals for projects so that we agree on this as a community and put this into the proposal. Of course, I mean, then if this has, of course, certain implications for the time after the 1 year. And then, Genevieve, I'll stop soon so you can add to this. I just had a spontaneous idea. Maybe you noticed these beautiful flags that we put out there. So we'll take one of the flags and put them at the Max Delbrück Center and on both campus actually, and put them up there. But I'm not sure how we are going to pay for this, but for at least our partners, okay? So one per country, we offer, if you want, send us an email, we'll send you a flag and you can put them in your institution. Actually, you know, I think I'm so excited about this, and I'm so thankful for you all being here and for all these discussions. I'm super happy about this. I think this meeting was a huge success. There was a lot of resonance, lots of different people coming, lots of ideas. So I'm now, I will fight with everything I have for this. Genevieve, you want to add to this?
I just want to say that I'm totally in line with what you said in terms of the excitement and the vibration that were really positive during these 2 days, and so we feel energized to keep going on this journey with you. And so you can certainly put your flag in your own institute to also show how strong you are behind this initiative. For sure, there's a lot more we need to do. So it's great to see that you're all here also to provide your input. And so you've seen this flag outside, but it's a way of communicating outside. But to communicate and continue with us, there was also this weird thing that you saw in the toilets, perhaps you didn't notice, in front of the tap. So there's this possibility for you to use this way of providing your input. So it's not only in the toilet, but I hope that you will provide us with input back. I'm joking. By all means, you can think of, because this is really, really important.
The next concrete step to do is the white paper. So here's a timeline. We will collect now all the work from the breakout sessions and discuss them thoroughly. We will also reach out to everybody who attended the conference with a survey. It is to us very important that you please give us feedback. We want to know what was good, what was bad, how to improve. If you don't give us feedback, we cannot improve, okay? So please do this, and these ideas and critique and so on will also shape the white paper. You can also, if you become an associate member, there would also a way to reflect this in the white paper. And we have also behind the scenes negotiated, you probably saw that the big 3 journals were here, and we negotiated with them, and so we will work with all of them for the next years to come. And I should say, if I say the big 3, everybody knows what I mean. But of course, there's also the number 4 journal, which is
very important
and
in Europe
on its own, which is a part of the discussion, of course. So, forgive me for this, but it's just how this is seen sometimes. So, just to say that we'll work with all these journals, it's just that the decision for the immediate white paper has been made. So it is one of the 4, and we intend to have a draft for this in 1 month after we have collected the feedback and to send this out and have the first viable version to look at in max 2 months from now. So this is a very important step for us, all of us, and I think we all, again, need your feedback and input and critique to make it the best possible product for us.
Okay, but perhaps just one more thing with this respect of communication. There's also the Scientific Advisory Board that will be interested to see what we can come up with. So we will have to provide them with this material so that they can also react and potentially provide a commentary on where we stand and help us for the future. So bear that in mind as well.
So we too, our job is to basically help the discussions, to enable the discussions and so on. Yeah, but I think what we should do now, ask at least 4 super important people to come on stage.
Please, Marie, Christian, Dörter, and Michael. Yes, please.
You have to be in the camera so that also people, this is streamed.
And they need to identify you so that they can bug you.
This is not possible, so please
come in.
Come up.
Come.
So these 4 have been putting together this conference and so much done for LifeTime. I think what we should really do is actually, I'm not sure if that's kind of usual, we should stand up and applaud. Can I ask you to do this?
Please.
There's Valentine missing, but he just joined very recently, and he'll get next time the proper applaud. Thank you. And Genevieve, you have a...
I want to thank you as well.
Okay, Genevieve.
So let's thank each other.
Okay. Ciao.
Thanks a lot.